Because it's going to be a long meeting, if we can keep the Chief Inspector's report, can we assume that we've read all the reports and just take questions, if that's all right, on the Chief Inspector's reports? Steve, is that all right?
We can take a hint.
I don't think there's any matters arising that aren't covered in the agenda. If there are, perhaps we can come back to them right at the end. So could we go, are we happy with the minutes? Is everyone happy with the minutes of the last meeting? Good, thank you. So David, can we go to your report, please?
Good morning, everybody. I'll take the hint as well. On the first report that came round, there was 8 items, and I think you've got a supplementary report which have an additional 3. I think the first 3 items, signposting, roadmap and update on transformation, are really about the transformation programme. There's further opportunities during the course of today for a conversation about this. John chaired a meeting yesterday which actually gave a fairly in-depth review, and I know he's going to report later in relation to this, so I'll steer clear of those things. But the first item is about signposting documents and handbooks. 2 signposting documents, you've seen these previously, have gone out saying effectively to acute healthcare and ambulances, this is how we're proposing to carry forward the inspection of your services, and is sending a signal to them, and then they can begin to think their way into that space. But critically, we'll also publish provider handbooks. There's 8 that we're proposing to publish in early April. They're out for consultation. The consultation runs from April to June. They'll then be revised in the light of those comments and published again in September, with a view to being good to go for the October change to the regulations that we also anticipate coming into force on the 1st of October. So that's beginning to align the new methodology with the new regulations and the legislation, and that is sending a signal to both services, and there'll be similar handbooks for our staff. So important documents that are giving a steer both to our staff and to the system. Allied to that is the roadmap. Later in today's agenda, you're being asked to agree as a board the business plan. And we wanted to wrap a narrative around the business plan, which is saying how that business plan relates to the 2-year roadmap, if you wish, why we're changing, what improvements we're making, and how we're organising ourselves to actually deliver those changes, and what are some of the critical issues. And that's the purpose of the roadmap. It will be a narrative which will explain what we do. I've mentioned the update on transformation. I'll not present each paragraph of this report, Chair, but effectively what we're doing is actually just outlining the progress we've made over the past few weeks. That's bringing in the new regulatory approach, the changes to the way that we're organised. We've begun the recruitment of additional staff and managers. We're beginning to put in place the training for our current staff that will be delivering the new methodologies, and we've also been doing an important piece of work, which is saying all outstanding issues around enforcement or complaints investigation must be handed from a current member of staff to a member of staff on the transition on the 1st of April. You can't just get up and walk away from the portfolio that you've got. You must hand it on to somebody else, and there must be a positive handover. Is really the risk we're attempting to mitigate. The risk we're attempting to mitigate is that complaints go unattended to, issues around safeguarding are left hanging between people. So Hillary's been overseeing quite a major piece of work, and those paragraphs are about that. Pulse survey. We do a major survey each July of all of our staff, and each February, well, the past 2 Februaries anyway, we've carried out a pulse survey, which is 25% of our staff. What I'm reporting on here, you'll get more detail on this in due course, is the initial results of the pulse survey. On page 4, we had a response rate of 81%. It was a random sample selected by GfK of 25% of our workforce. I think N is 691 from memory. And the top 5 scores we've set out in this note about improvements in our colleagues agreeing that we are going in the right direction, that we're clear about why we exist and what we're doing, and the support of the staff, 86% positive, a 12% increase for the future direction of the organisation. Significant improvements. I'm always slightly wary of actually large-scale changes, but we've got the largest increase is a 20% increase in staff reporting that they feel proud to work for CQC, which has gone up from 57% to 77%. And also significant increases at 12% of people recommending CQC as a good place to work, up 12%. From 53 to 65. The lowest 5 scores are around communication, morale, whether change is being effectively managed, whether people feel valued, and the issue about accessibility of culture. They all show an increase. They're all movements in the right direction with the exception of communication. I'm very pleased with these scores, Chair, because I think this was a poll that was taking place while 1,300 people had the anxiety and uncertainty of actually selecting a preference for a role. And I think it speaks well of the organisation and the effort that has gone on. I think it'd be wrong to be complacent. These are good improvements, but there's still scores that we should be more ambitious about in terms of staff satisfaction. Interestingly, the very last paragraph here is we asked people what would be the 3 top factors that would help and support people to do the job, and it was about systems and processes, equipping people with the necessary skills to do the work, and improving people's work-life balance. So much there to chew on as we move forward, but really very, very good. There's an issue about what we're doing here. I think it's important that we actually publish this work, that we are transparent about where we've made improvements and where we've not made improvement. Comments really about morale come into this. Interesting in this is that personal morale is good at 62%. It's gone up by 9%, so that's 6 out of 10 of our staff have personal, their morale is good. Interestingly though, that morale is good in CQC, so when they're speaking of others, only 35%, that's an 11% increase, so we actually need to really understand and explore that much more. People feel good about themselves and their own morale, but less good about the organisation, so I think there's some significant challenges in that, and it seems to me that by publishing that and having an open debate about that is absolutely the right way to go, rather than actually being slightly gentle about this. We actually need to tackle this in a pretty upfront way. John, I think, in the audit committee has been through a number of fraud investigations, and I just wanted to draw attention to those, but there's a fuller report on the audit committee which goes into these. I want to draw attention to some further work we've been doing on whistleblowing, where I'm pleased to say that we've been able to secure Dr. Kim Holt's services for a 3-month secondment to CQC, where she'll work part-time and help us develop our work, the work that Michael Myers leading on whistleblowing. And I think she'll add real value and challenge to the work that we're doing and our thinking. On registered managers, Chair, I just want to you'll know as a board that we've had previous discussions about taking action against those services where there's not a registered manager. That work has progressed well, but one of the issues has come out as that's being delivered is some pushback, more from dental practitioners than other services, but certainly from some other services as well, about the requirement to have a registered manager. A number of them have pushed back on the basis that they didn't feel there'd been an adequate explanation from CQC of the requirement to have a registered manager, and that where we were going to take action in relation to a fixed penalty notice had not been a proactive approach to them setting out that that's what they were going to do. As a consequence of that pushback, colleagues have reviewed the approach that we've been taking, and we've now changed and emphasised the importance of a direct contact with dental practitioners, either a visit or a conversation with them, and will write out to all dental practitioners and indeed all providers around the operation of that fixed penalty notice. That pushback has resulted in letters from MPs, my calculation about between half a dozen and a dozen, but a number of contacts from dental advisors. Steve's been speaking to the trade associations for dental advisors, and as I say, a letter will go out in my name setting that out. I don't know whether board members have been approached individually. I know, David, you've had letters, so I hope that gives some explanation of where we're up to. The note that was sent round supplementary, since drafting the note, Chief Exec's report, there were 3 pretty important publications that took place. Firstly, the Dalton-Williams review. David Dalton and Professor Williams, the President of the Royal College of Surgeons, were asked by the Secretary of State to carry out a review of the threshold for the duty of candour and the way that that will be taken forward. They reported in the past few days. Interestingly, they've gone for a new definition of significant harm, which is very similar to the report that we considered when we debated the CQC position at a board meeting 2 or 3 meetings ago. What will now happen is the government will respond to that, and we anticipate regulations will be required, and those regulations will be consulted on in the ambition that they'll be ready for October, and then that's a regulatory framework that we will be asked to operate within in relation to the duty of candour. I've also flagged up in the report that the Think Local Like Personal Partnership were asked by government to look at the application of the duty of candour to adult social care, so not just into the NHS, and we've highlighted that there. I'll report again when the regulations are drafted and we have got a sense of what we're dealing with. The Lords have done some work on the Mental Capacity Act, and they published a pretty hard-hitting report, I have to say, last week in relation to the operation of the mental capacity legislation. Many of the messages resonate with the ones that were in our annual report on mental capacity. The language was slightly different, but the issues that they were raising had resonance. I'm not entirely sure how the government's going to respond to that. It was only published last week, so the government will need to take some time to digest that and respond to that, but there will be implications from that government response for us in the way that we move forward. And then the last thing, David, just to flag, is the peer review body report, which they've clarified, governments have clarified that the 1% for staff is applicable to CQC. There won't be a prevention of doing that, but the no increases for very senior managers will apply to CQC. So what we'll do is there'll be a report prepared to go to the Remuneration Committee, which will set out how that can be taken forward. So that's all I wanted to share with you. Thanks, Chair.
Question, Dave, Lewis.
Thanks very much. David, can I just ask you about the last thing you raised, which is the Mental Capacity Act report? Because you're right that the implications are potentially very significant, including for CQC, in the sense that the main recommendation was a new oversight body for the Mental Capacity Act. And the model was explicitly the old Mental Health Act Commission, which of course is now merged, or was one of the merging organisations to form CQC. And I must say I had some concerns about that because what the rest of the difficulty that the Mental Capacity Act has been in is about embedding it in the system so that practitioners across the health and social care field understand it and use it and get what it's for, not just what it might limit people about, but what it might allow for people. And it may, the idea of setting up a new sort of oversight body separate from all the other bodies that are around, didn't sound like a recipe for integration into the system as a whole. Obviously, one possibility is that the oversight body might have close links with CQC. It might even be CQC. Do you have any feel for where that's heading?
No. To the best of my knowledge, I'm not sure that the department knew exactly what the Lords Committee were going to say beforehand. I'm sure there was a courtesy extended at the time of publication, but I don't think there's been a bank of civil servants working on what the response is going to be to this. So I think that's to play for. I thought the wording was interesting, that they weren't specific about creating a new organisation. They actually just said there needs to be an oversight body. So I've not done a textual analysis of it. Lewis, somebody needs to do that. I think there is an issue. I think people that are responsible for running services need to take responsibility for ensuring their staff have the knowledge and the skills to deliver that. That's what we were trying to say in our evidence to the committee, that the responsibility should be with professional organisations, clinical leadership, the employers of organisations, to ensure that their staff are aware and knowledgeable of what the legislation is. In interviews, when we published our report, the media were saying this is a bad thing, and I was saying actually the Mental Capacity Act in its ambition is a good thing. This is about stopping the woman who gets up at 4 o'clock in the morning, who says, in a care home dressed in her 90s, saying, I'm off to school now, is that actually they're helped and supported to be in the moment that they're in, and they're not allowed to go out in -2, 3 temperatures because they're going to school, because that's what they choose to do. And if that was one of our family members, I think we'd have a view about whether they were allowed to go out. So I think there is a deeply important issue that underpins this that needs to be teased out. I think the Lords, with their normal sagacity, applied themselves to this, but I think there now needs to be a debate about, well, what that means for what we're going to do, and there will be implications for us, and we need to join in those conversations. But it's too early, Lewis. I think it was published last Wednesday or Thursday.
Just to say, I mean, the obvious, which is the really good results from the Pulse survey. Congratulations, considering also all the transformational change going on. So really, that's really good news. I just had a small question about the latest intelligent monitoring information on acute and specialist trust that was published on the 13th of March. Was there much press interest in that? And also, was there much consistency with our previous list? If you remember, we had a conversation, I think Lewis was at the heart of that, about the volatility of certain measures. So did our bands change a great deal with the second list? Thank you.
Paul, do you want to have a crack at that?
Yeah. So there was certainly less media interest than there had been in the previous publication, which I think was probably in part down to us spending more time engaging with Trust. So Trust knew it was coming. They had a full 2 weeks to comment on the individual pieces of data, and made a number of changes as a result of that. In terms of the similarity, from memory, there was, if we just plot one against the other, there was something like 60 or just over 60% correlation trust to trust on band. The main reason why there were differences were changes in the indicators rather than changes due to people's position within the same indicator. There were one trust from North West London hospitals that came into band 1. There were a number of hospitals that went down from relatively high risk right the way down to bands 5 or 6, which, although it's not a judgment, is as much a good sign as anything, that people are on top of the risks that they face.
Did you want to say anything about it from your own observations?
Other than this is developing, and the volatility is an issue, as we've pointed out before. But I think I'm pleased that there's less press interest, because I don't think we should be putting too much weight on that publication compared to the inspections, for the obvious reasons that Mike sets out in his reports.
I think one of the things that we did in this publication was refer to the bands as priority bands for inspection, because that's how we see it. This is not the judgment, as Paul was saying. This is helping us to know where we might go sooner rather than later. And as Paul was saying, the changes aren't huge. Some have improved considerably. It'll be interesting to see why that is, but on the whole, there haven't been huge shifts.
actually, Jennifer's done it. I just wanted to say congratulations to the staff team. I thought it was a great result. More to be done, but excellent result.
Yes, I mean, I agree about the survey as well. The point I had was about the handbooks, and David said that they will be very important documents. And I wondered if they'd been patient-proofed, because, you know, we need to make sure that everything that we publish does actually lead to patients having good outcomes, better experiences. So I know they're going out for consultation now, so I wondered if there was any particular consultation planned with patient or service user groups, just to have a look at them and say, well, you know, this doesn't make sense from where I'm sitting, or it should, you know, in a very sort of general sense.
Yes, absolutely. So part of the engagement process of the 8-week consultation will be with patient groups, and that's alongside the co-production that we've done across the different sectors in the run-up to these documents.
Good, David, thanks. I'd just like to say on the Pulse report, I mean, I think, you know, a huge tribute to you, David, actually. I mean, it's really tough to keep people engaged and motivated at a time of change, and I think you've done a fantastic job on that, so well done. Right, next item. I've lost my agenda now. Evaluation of Wave 1. Mike, it's you.
I think my task here is to introduce Kieran Walsh, who's done the work. We were committed from the outset to evaluating Wave 1 as we went along, Wave 1 and Wave 2, so that we can then bring the knowledge from that into our programmes. And as you will hear, we already have done made some of those changes, but maybe just hand over to Kieran to give us an overview. People have seen the paper anyway, but give us a flavour.
Thanks very much, Mike. And if you're happy, David, I was going to talk only for sort of 5 or 8 minutes, and not to reproduce what's in the report, but to try and offer some thoughts about what it says for future directions. Many thanks for the invitation, by the way, to come to the board today, and for asking us to do the research. I did also want to say thank you to the staff from CQC, right the way from Mike and the heads of hospital inspection through all the inspection teams and people in hospitals who, in our research, we've taken up quite a bit of their time, and they've been unfailingly helpful and thoughtful and very honest about how the new inspection model has been working in the acute sector. It's signalled on your agenda, I think, as a final report, but this is an interim report for us. We're continuing to do some research, and we'll report again at the end of May. In broad terms, the strong positives are there was a universal sense of support for the direction of the new regulatory model. I don't think I've met anybody in this research who doesn't think that this is the right thing to do. There's also near universal support from hospitals and from inspection team members we've interviewed that the new model is a step change in terms of rigour and credibility. There is a widespread sense that the pace of its development has been hugely challenging, but probably the right thing to do. And we have been struck by how much those involved have been trying to do to develop the process as they go. In other words, to embed some learnings, as Mike said, as it progressed. The 3 challenges, I think, that emerge from the evaluation so far are cost, consistency, and impact. So what the process costs and its resource use, the consistency of the process and of the judgments and ratings it involves, and what impact it will have on the quality of care and on quality improvement. I want to come back to those at the end. Any inspection system like this, and I've spent time looking at other people's too, is essentially founded on 3 things. It's founded on the standards of care that you express, on the processes of inspection you put in place, and on the people who do it. And I thought it might be helpful to use those 3 headings just to summarise some of the things that we've found. On the standards of care, this is how you as a regulator express your expectations of the organisations that you're regulating, what you think they need to do, how you say what represents good or outstanding performance in safety in maternity care, for example. And it's important because that's not only used by hospitals to understand what they need to do, It's the way you communicate your requirements to them, but it's also used by inspection teams in making the judgments and ratings that they reach and in writing the narrative of their reports. In the process at the moment, those standards are pretty much implicit. There are elements of the standards, if you like, embedded in the key lines of inquiry, in the data pack, in the choice of core service areas which you're focusing in on, the domains that have been defined. But a great deal is left to professional judgment at the moment. And there are some areas, of course, that aren't covered by those standards at present. I think looking forward, the challenge is to find a way of being more explicit about those expectations and yet not foreclosing the space for professional judgment and discretion in the way that inspectors understand and interpret those standards. But I would suggest that there is going to be a need to move towards being much clearer about the articulation of, in my example, what represents outstanding performance in safety in maternity care. I'm happy to pause as I go along or carry on.
Could you just give an example of that? Can you just be really, really explicit about what that would mean?
Well, those standards might be, I mean, one approach to this would be to bring together the people who've been involved in inspections in, if I take the example of maternity care, those people who've been involved in inspections and draw on their experience of inspecting organisations to say, well, having inspected and looking across our inspection so far, how would we describe or how would we articulate in more detail at a core service area for maternity those grade descriptors of outstanding, good, requires improvement and poor, so that then an issue like, for example, if I take a really practical example, issues to do with the cleanliness of delivery rooms, which have arisen in a number of inspections, your inspectors have a common sense of where that fits into their interpretation of the quality of care. Now, other inspectorates have ended up getting into a process in which they develop more and more detailed standards as they try harder and harder to close off and articulate every potential area of debate. And I think that's something you will want, I'm sure, to avoid, to see from nods around the table. But there, I think, is a middle way between having Joint Commission style 1,000-page handbooks of numbered standards and the position at the moment where it's quite hard to articulate to an organisation what represents outstanding care in a particular area. Does that help? Should I carry on the three areas and then come back? So standards was one issue I raised. The second two were processes and people. Second and third were processes and people. On processes, this is the mechanisms by which you inspect, the processes of data collection, data synthesis and interpretation, the tools and protocols that you use, and the way you arrive at your narrative and rating. There's more guidance in this area, and it's been interesting to see how that has developed over the period of Wave 1 and 2 in the inspection guide, the data pack, the timetables for inspections, the guidance on how to use things like interviews, focus groups, and so on. But our observation of the process is that it's still largely inductive and pretty much self-directed by teams. This is an area where we've seen teams struggling with the structured and unstructured nature of the data that they deal with. So they've had lots of information provided by trusts, and it's really challenging for them to synthesize, interpret, and then use that data. So I think in this area too, our suggestion would be that you think the learning is that there's a need for greater structure or more use of frameworks to guide that process. And that might involve more structured inquiries of trusts in advance of inspection so that they populate a framework of data rather than providing, as they do at the moment, hundreds of documents with information that the inspection team then has to try and make sense of. But also then more targeted forms of fieldwork driven by that data. And that, I think, has been an ambition from the start, that the data should drive the fieldwork. In practice, that's been really hard to do, partly because some of the data hasn't existed at the level of granularity that's needed. So in that second area, it's, again, I think, more structure to the process. And the third area, the people who do the inspection, this is the CQC staff and the wider inspection team. Other inspectorates I've talked to have said this is the really hard area to get right. The people who do it are crucial. And they clearly have to combine a kind of content expertise in acute care, an understanding of regulatory process, And not to be underestimated, really strong interpersonal skills in enacting the process of inspection. Several people have observed to me about the inspectors. They are the public face of the organisation. They're the people who clinicians and leaders in acute organisations will meet, and by whose conduct they will judge the organisation. Clearly, the pace of this programme has been a real challenge, and I think it's been logistics and timescales that have driven the selection of people to undertake inspections. And it's been marked that the people we've interviewed have been hugely enthusiastic about doing that for all sorts of reasons, but they have been very willing to step up to being involved in inspections. Moving forward, I think the learning would be that there will have to be more of a selection process, which I think is already being enacted. Also, greater focus on training and qualification. So in other words, can somebody be put forward to be an inspector, but actually you judge as an organisation they don't have the skills to undertake the tasks that are required. And to do it well, other inspectorates have found people have to make some kind of minimum commitment to taking on the task. There are also issues to do with the way you then deploy those people. How, for example, you build and sustain teams in the inspectorate so that you don't simply ask people to inspect with people that they may not have met before, how you appraise the performance of individual members of inspection teams, and so on. So I suppose in conclusion, that was all I was going to say on those three areas. It has been a privilege to watch the process starting, and really interesting and impressive to see the degree of change over a short space of time. In those three areas of cost, consistency and impact, I think that changes to embrace greater structure, greater organisation of process and selectivity around people might help to address the issues of cost in the process. But I think the cost of inspecting £500 million turnover organisations is always going to be high, and you have to balance cost of inspection against cost of service. Consistency is the area I suspect you'll have some questions and debate about. Structure in standards and processes is probably essential to getting consistency in ratings. But there are other things we could talk about that might help to move towards consistency in the rating process. And impact is the poor relation here in some ways, because I've said almost nothing about it, and so far we have very little data about it. We've observed quality summits, but not gone beyond that. I think the experience of others is that that's actually, in the longer term, the medium and longer term, the area where you want to focus some effort in assuring yourself that the process of inspection yields worthwhile impact. But that's not something we've touched on. So David, I'll stop there. I hope that's helpful.
Kieran, thank you very much for that. Mike, do you just want to respond to that, give your observations before we open it up for a general chat?
My immediate response is that I think that Kieran and his team have done an incredibly thoughtful and insightful piece of work. They have actually been very easy to work with because, as you know, these inspections are very large and you've got lots and lots of people in a room. But so we, the inspectors, are out there inspecting the trusts, but we are being inspected, if you like. But they have made that completely bearable at all times. And I think in terms of the findings, which is the both the sort of his analysis of the key areas and the findings, I just wholeheartedly agree, and would say that I do think we're on the case with each of the areas. We are working towards the standards. This is the work on what good looks like, and I think when we come to the provider handbooks, we will already be a step down that line. Not saying we will have got it completely right, and I think that will go on over time, but we're getting a lot closer to that. I think partly we're now in a position where we can start working backwards by looking at what the reports look like, and actually saying how should that influence what we do in inspection and what we do before inspection in order to get reports that are consistent in particular. And we are already modifying our process of inspection. I think there is you know, we are finding the data packs extremely valuable, but we all know that they could go further, particularly if they are organised by core service. They will be used more by the inspection teams if the relevant data is just there for them to look at and to inform their lines of inquiry. We've slightly changed the timetables of the inspections. For example, we get the chief executive of the trust to give us a presentation on our so-called day naught, the training and planning day, and that's valuable for getting people at least to hear what the chief executive thinks about the context of the trust, the challenges of the trust, and indeed what they're proud of. Again, the more that we can do the focus groups early, because they are really hypothesis generating, and the interviews with senior management late in the process, because they are probing when we've already got information. I think that is something that we're changing as we go along. So we have changed the process of inspection. People, I would agree with Kieran, is all important. I think we've been extremely fortunate to be able to get the people we have had so far. But we need to build up a bank of people who do this with a sort of minimum commitment. I think they're there. The people we've had have tended to say, when can I come back? So, which is extremely good news. But we need to do more thorough selection and training, and of course training of our own staff. This is a very different process for them, and particularly when it comes back to the standards of care. What does good look like? That's not something that we have been really expecting them to look at in the past, and so we need to train them in that, and that's where the interplay between the clinical experts and the CQC inspectors will come in. We have already developed a conversion training program, but we need to do more on that over time. And we need to combine the skills of inspectors who are really good at ferreting out the things that need to be looked for with the clinicians who are sometimes good at looking at the big picture. So I think all of those things are in progress, and it's very useful to have this report against which we can then say, are we doing the right things?
Lewis, yeah.
Well, I thought it was a very interesting report, very good report actually, very encouraging. I want to ask about credibility among clinicians, because just last week I was giving a talk to the Royal College of Psychiatrists forensic section, and initially they asked me to give a talk about safety in mental health care, but by the time they produced the programme, my talk was called CQC Friend or Foe. And I think that goes to the heart of how clinicians view CQC. Is it a friend or a foe? So the question is about credibility. And at the conference itself, people raised a couple of things with me. One of them was about the reliability issue. So I suppose they were calling for something that was reliable, therefore more structured, more standardised, but without... this is my bit, they didn't say this, but without bunching ratings in the middle to such an extent that that they're very reliable but don't actually mean very much. So that was one thing. Second thing was the seniority of the inspectors, because they were in a very particular specialty where they I don't think they didn't really think that even general psychiatrists could properly inspect the specialty that they deliver. And there's probably some truth in that. So getting that specialist expertise they saw as key to credibility. And I must say that the inspectors, I've been on a couple of inspections under the old system, and I must say I've been really impressed by the inspection teams and what they bring, the expertise and the astuteness that they bring to inspections, but turning that into something which clinicians recognise will be important. And then the third thing is more difficult. The third thing is about fairness. And now bear in mind this is in mental health, where people feel that they are historically disadvantaged in funding and in priority in the NHS. They felt that one of their main worries was that they would end up carrying the can for the failings of other parts of the system, so that their service might be rated down because their commissioners don't care about mental health, or because historically all the money's tied up in elective surgery, or something like that. So there's an issue of fairness, which they were worried about. So clinical credibility is my question.
I'll quickly respond then.
You start.
Mike will, I'm sure, have a more considered view to offer. I think the clinical credibility of clinical members of the team is hugely important, and that's partly about currency and their engagement in current practice. It's currently about their place in the, if you like, the spectrum of the area, them being seen not just as, members of that specialty, but leading members of that specialty. But it's also about their connection with the specialty itself. And you make the point that we live with a sort of ever-fragmenting set of specialties and subspecialties. And even with the largest teams that CQC has managed to assemble for these first two waves, it's not been possible to have people who cover every specialty and subspecialty. What is striking is that some team members, I would suggest, are much better than others at parlaying their clinical expertise into other areas. And it's unsurprisingly, I think it's medical directors, perhaps, who've got the most experience of doing that, and so are therefore able to act more as generalists. But I don't think you're ever going to be able to have teams where you manage to replicate every specialty or subspecialty. But the fact that the people on the team are seen as clinically credible, current, and leaders of some kind in their specialty, I think is really important.
But just to reassure you that the degree of specialism does come into this. So to take the mental health inspections, which were clearly in their first wave at the moment, by defining core services within mental health, we would have people who understand about forensic, looking at the forensic wards. We would have people who understand about eating disorders looking there. We would have people who understand about CAMS looking at CAMS. So we're not expecting a general psychiatrist to do it all any more than we are in the acute sector, where, yes, indeed, I think the medical director role is very valuable because they can see across a span, but having people that really know about A&E or intensive care or maternity is also very important, and we do try to get that balance. So if one of our sub-teams is looking at maternity and children, we would probably want to have at least one person who was maternity, but that could well be a midwife, a very senior midwife, and then perhaps a paediatrician alongside. So it all depends then how big the teams get, whether we have to have one of everything. But I think it's getting that balance right, and we will constantly review that.
Thank you for a very good report, admirably pithy. Thank you. My points are a couple of points. Wider point first. There's a very febrile atmosphere in the service at the moment. It seems very chaotic, uncertain. Some people are saying it's akin to the eve of the First World War. We know the Everest to climb, but actually the gun hasn't been shot yet. It seems to me, I think I put in an email to you, David, that the undercurrents are definitely that if there's a weighing scales, on one side there's scrutiny and clobber in the system, and the other side is support, that the scrutiny and clobber scales are far more weighted down than the support element. And we, at the moment, I think, are largely in the scrutiny, and we're not clobber, but we're in the scrutiny sort of side of the balance. And I just noticed your statement here, Kieran, where you say that unclear whether those represented at the summit and subsequently responsible for holding the trust to account, or indeed responsible for helping, is unclear. And at a meeting that I was with other ALB chiefs recently, I felt that there wasn't a cohesive view necessarily in the system about where support should come from and how people should link together the ALBs more generally. So I think while we are polishing our mirror, our scrutiny element, I really do think that we should be overtly working with others to think about how better this balance could be better corrected as we go forward. I think that's very important for us, and it's important for the system. So I think what is done after those summits with TDA, with Monitor, who we're very used to clobbering, that's where they come from, and NHS England, what we do and how we can lead that is an important point, I think. I think that's the main point I wanted to make. On the subspecialisation point, the only link I thought that could be useful here for us is all the efforts that are now going into perhaps developing the peer review services in specialties and subspecialties, and that actually if they could only, if some priorities of that initiative could be to get more information and have the subspecialists scrutinise themselves before we arrive, then we could rely on that without us having to go there in finer detail. Thank you.
Paul, is it on Jennifer's first point? Yeah, then we'll... Yeah.
In a sense, this is to the board as much as to Kieran, but because it's a request for sort of research mission creep, really. And it's precisely about impact and outcomes and improvement. Because you've actually been there at the quality summits, this is an area which is absolutely crucial to our work, but actually we're not involved in at all. But we're involved in the summits, but actually, you know, the nature of improvement is other people's work. And it would be really, and I think my worry is as a board, we might start researching this in a couple of years' time, which would be too late. And I think it would be very interesting to follow through a couple of post-inspection activities or non-activities for several months and to research what happens. And just to see if it's picked up, if we're ever referred to. You know, once we're not there, do we disappear from the world? You know, those are the sorts of things that I think would be really useful to know. And if then there is any form of improvement organisation that's assisting, because it's you know, if this doesn't happen, we as an organisation have got real problems, as have all of the organisations we're inspecting.
Just before we go back to Kieran and Mike, Paul, you wanted to pick up, I think, on Jennifer's last point about specialty ratings or specialty analysis before we go back to Mike and Kieran.
Yeah, the point about using peer review and clinical audit. So when we put out the Wave 1 report, which was very linked to and in the same space as the findings that Kieran has in his interim report, this was one of the key bits that Mike highlighted, was that providers themselves don't often know what the effectiveness of their service is, and part of our way of getting into that is going to be on-site inspection with specialists. But a very serious part of it's got to be the data from peer review and clinical audit, so to endorse completely what you're saying, Jennifer.
Mike or Kieran, which...
Shall I make a start and then Kieran... Can I actually pick up one point that I didn't respond to Paul, to Lewis on, which was the fairness in carrying the can. I mean, clearly, we are there largely on behalf of the patient, not on behalf of the provider or the commissioner. We need to say it as it is. I think by saying it as it is, that will actually help a great deal. And by being able to look across, from my position, between mental health and the acute sector, actually being able to say, is there a level playing field here? And I think that will be very valuable. So if there are patients who are elderly and have dementia, who could be either in an acute hospital or could be in a mental health facility, have we got a level playing field there in terms of the care that is being provided? So I think we will be pointing out things that are uncomfortable in all the sectors that we look at, and in some cases, when it comes to the Quality Summit, people will be undoubtedly saying, yes, but that isn't commissioned. And so that might be about people having to be moved a long way away to find a psychiatric intensive care unit, for example. Those points we will be exploring, and it may just be that there isn't one within a reasonable distance. So I think we will just say that as it is when it comes out. And I hope that will contribute to fairness, is my view. In terms of the summits, I've now attended several summits, and I think you won't be surprised to hear that they differ depending on what we have found. So if we have found very good services throughout, they are largely a celebration. If we have found areas where there is a lot that requires improvement, they're hard grind about who's going to be doing what. But we do have all the relevant people in the room for those summits. We make the presentation about what we have found, and I hope that by being clear about what we've found, that actually tells people really what needs to be done. We have there the Trust who then respond, but also the CCGs, the local authorities, a wide range of others, Local Health Watch, etc., who will comment. And actually the final part of the summit is a working meeting where people all say, okay, what do we need to do? So if I take the Barts Health Summit, where we issued, I think it was 15 compliance actions, one of the things that people were doing at different tables was working through what are we going to do to resolve those 15 compliance actions. And of course, we don't disappear afterwards. We will go back and check up on those compliance actions and any warning notices as well. So we will be coming back, and they know that. We will have the opportunity over the next few months to at least look at the KEO trusts that, which we are going to be re-inspecting. Now, I know the methodology was not entirely the same, but we will be able to see to a certain degree what action has transpired as a result of that, which I think will also be useful. Following up on Paul's point about peer review and accreditation, absolutely. I mean, what we are doing is saying which are the accreditation and peer review programs that can contribute usefully to what we're doing. We are looking at them in terms of what do they tell us about safety, effectiveness, caring, responsive, well-led for their areas. But we already have things like the cancer peer review programs. I think the diagnostic programs, at the moment we do not have radiology and pathology as core services, but getting information in from their accreditation and peer review programs will be enormously valuable, and over time we will bring more in as well.
And could you pick up Paul's point about measuring the impact of...
Yeah. I think we are getting from this piece of work some early information about impact. So we are just starting to survey individuals in the Wave 2 NHS trusts after the Quality Summit to gather some information about both their views of the process of inspection and their engagement in it, but also their views about the report. So we're asking them questions about to what degree they think the report has added to knowledge about the quality and performance of the organisation, but we're also asking them about early action planning. But clearly that's about a week or 2 weeks after the Quality Summit, and that's very early in the process. So I think it would be worth going back to trusts in Wave 1 fairly soon to ask the question of a number of stakeholders, to what degree you can trace through marker actions from the report to see them acted on. It is a challenge always for regulators to work out to what degree they want to take responsibility for follow-up and improvement, because it is clearly not your job to enact that improvement, but it is your job to see it enacted.
So, kind of just following on from that, it seems to me that the third party, if you like, the collective third party that's not so much in this report, and I think it's because it's the way that it's been scoped and we've conceived of it, are all of those organisations who operate at a local and community level, on whom we depend quite heavily, both for the intelligence that goes into the process, including the information, the public meetings and so on. Plus, they are, many of them, going to be key players in kind of at least challenging, if not supporting, to ensure that some change actually happens once we've left. And there's not, I mean, there's not very much at all in here, and I think that's because it wasn't in the brief. But I think it will be really important. I mean, so maybe this is scope creep, and it's not unrelated to the points about impact, but either in your final report, if you can, certainly if we do any further reports on other on the other inspection regimes as they come in, I think we really need to make sure that we talk not just to the regulated community and to the people who are doing the inspections, but also to those third-party organisations, because if they don't feel that they've been properly engaged and involved from beginning to end, they won't be involved in the end. They won't kind of stick with it. They won't play their part. Now, as you say, that's not our responsibility, but we could make it less likely to happen by the way that we engage or don't engage with those people. So, I mean, obviously in that I am thinking partly and parochially about Local Health Watch, but not only Local Health Watch. You know, if we find there are issues about particular pathways in a licensed entity of some sort, then we will want the help of, you know, Local Mind or local Diabetes UK or whatever it is to kind of work on improvement. So I think we need to be a bit more structured in our thinking about this generally, and and that means thinking about the three parties, not just the two. Just to offer that one of the things that that we're doing or thinking of doing at Healthwatch England over the next month is bringing together the local health watches in the areas where first wave inspections happen to get a bit of a view about how they feel about that process. And I know it will be very mixed, and we've talked about this before, Mike, but hopefully that will give us a bit of local learning. But it's not the only thing they're not the only people in town.
Thanks, Anna. Rather than pick that up now, can we just go to Steve and Kay, and then take the three together?
Yes,
Steve.
thank you, Chair. And I thought the report was very good and very helpful. I just wanted to say something from the primary care sort of angle, because this is a paper focused on what we've been doing in acute. But in the work I've been doing over a number of years now, both on developing examination systems but also inspections for training, your findings chime really well with what we discovered in primary care, as you would expect it to be. So we'll take some of the lessons from there. I wanted to say a couple of things. One was about improvement and the balance, again, I think Jennifer's point is really important between, I wouldn't call it clobber, but certainly scrutiny and demand versus quality improvement. And in our strapline, it's about encouraging improvement, isn't it, in what we're doing, but we're not the improvement body. In primary care GP land, we don't have a trust development authority. And one of my big concerns is who is going to support the improvement in primary care when issues are identified. Now, on one hand, you could argue that GP practices are independent contractors or increasingly chains or bigger groups, and they have a responsibility. On the other hand, I think the state also has a responsibility through NHS England, of which they are not funded for that activity. And so some work does need to be done looking at the balance between the responsibility of the contractor and NHS England as the commissioner, and the relationship with, and I'm with Anna on this, about how we use other groups to improve the care. So if you look at homeless care, the practices that are doing really, really well actively engage with local charities, housing associations, and the national body Homeless Link. And the best projects that have come out recently have been co-productions of the third sector, primary and secondary care. And I think that, Anna, is a really, really important message on that. I think looking at consistency, which we've talked about at the board frequently, for me that's the number one issue, about how we ensure consistency of decisions, judgments, ratings, if you're in Cornwall or in central Birmingham, whether you're in Tower Hamlets or in Newcastle. And the funding going into primary care does vary, even on a road varies, and therefore we will need to look at the context of the practice, but the judgments should be the same. And we've looked at, because we're behind, Mike, thankfully, on time, investing right up front on selection and training, because we know from examinations that doctors in the surgery make judgments quickly based on information confirmed on examination using investigations. But when you put a doctor into an examination or an inspection regime, they're not necessarily as good as they are in the surgery, and therefore there are hawks and doves. And so initial training and feedback is going to be so important, and that's where we're spending a lot of time. So your paper is really helpful because it helps put weight behind what we're trying to do. Thank you.
Okay.
Yep. I mean, yeah, I agree. The report's very helpful and certainly chimes with what I saw when I joined one of the inspections. And of course, from the outset, we were saying that we were sort of learning through doing, and we've learnt a lot and we've done a lot. So it's, and I think the single most impressive thing for me was that everyone seems to support the direction we're going in and what we're doing. So that's really important. My main issue was, it may be because you weren't asked to look at it, but there's not really anything in here about sort of patient and public voice. So, for example, I don't know, if I just read this, I wouldn't know how or if we, how we sought the voice of people who were using the services, the patients. Because I know there were listening events and I know there was some talking to patients, but I just don't know if that, what was done really or how well it worked. And also, the other side of that is, in terms of our experts by experience. I know they were part of all the inspections, I think, but I'm not sure, how well that worked or what their views were, or, and it'll be useful to have that at least, in the future, if not now.
Sorry. I'm going to could you respond to those 3 points that have been made, and then I'm going to ask Michael just to say a few words after that. And then, Andrew, did you want to say something as well?
I would, but afterward.
Okay.
Afterwards, it's fine.
I mean, if I can take Anna's and Kay's points together, because I think they're covering similar ground, clearly incredibly important that we do hear the voice of the public, but also the users of individual services, and how we best do that. As you know, we've had the open public and patient listening events. We've also, on top of that, tried to go out in advance of those to particular local groups to ask them for their opinions. We've always come to Local Health Watch to ask them to give us information during the pre-inspection phase. I think we can do better. We also have the survey data. And there's the CQC inpatient survey, which gives us a broad picture of what patients are saying about that hospital in comparison with others. That has the great advantage that it is robust across the country. I think now, of course, very recently we've got the maternity survey, and we will soon be having a children's survey as well. So I think we are getting a more robust picture related to different aspects of acute hospitals. But I think we need to think about, could we go further than that? So could we, it would be at least theoretically possible, for example, to say to a trust, can we have the names of people who've recently had children, or could they write out to the recent mothers, and so that we can specifically ask them to a focus group, or indeed to people who've recently been bereaved, and we could ask them what their experience has been. So I think there are different ways that we can develop this and see what works. We do, of course, also have all sorts of other channels like email and correspondence, and we do make sure that the correspondence about a particular trust that we've had is collated as part of the pre-inspection work, so that we know, for example, whether there have been either complaints or concerns, or indeed whistleblowing events. So I think we do try to bring all that together. I'm not saying we're doing it as well as we could, but we certainly are very keen to make sure that we do hear that voice. Anna.
I'm sorry. I just. I mean, that's helpful, and I know that, and I'm sure there are improvements that we can make there, Mike. But I'm not just talking about the inputs. I'm talking about the potential value added of individuals in the community and organisations in the community who can make change happen by being involved in it afterwards. And it's something about not just thinking about engaging with the public as helping improve our inspection regime. It's about engaging with the public and the organisations in the community in order to help improvement happen. And that's a slightly different objective.
It is, but again, of course, that technically the primary responsibility for that lies with the provider. And there are, we've already seen some providers that are doing that fantastically well, and some that are doing it much less well.
And my only comment is I think the way we do the inspection and the way that we engage those organisations will have an impact on their willingness to help later. So it's not that we're responsible for it, but we can have a significant and potentially detrimental impact on it if we don't engage people in the right way.
On that point, Camilla, you wanted to come in.
Yeah, Anna, I think it would be really helpful if you could say what you think Healthwatch's role is in that and where you think Healthwatch can't do that. Because do you see what I mean? Because quite a lot of that would be great, obviously, coming from you, wouldn't it?
So I think local Healthwatch can do some of that. So I think certainly local Healthwatch could help to direct the CQC as it's building its inspection protocol to the right kind of other people to talk to in the local community. So, I mean, it's a bit like an extension of their signposting and information role. They know who's active in the community at the kind of community organisation level who could be useful inputs to this. I don't think they should be the conduit then for that conversation between CQC and those organisations. But CQC inspectors themselves are also locally very involved with those organisations. So, I mean, I don't think Local Healthwatch is the only source of information. And I think, you know, one of the very important things that needs to happen between now and the final versions of the inspection regime is a clarification about what we can usefully contribute without duplicating what other people do, and that's a two-way conversation, because there's a question about capability and resource at the local Healthwatch level, as well as which we will need to support, as well as what other people are able to contribute. So I think it's a good question, Camilla. In a way, I can't tell you the whole answer because I don't think it's properly developed, but I think there is a very important role for local Healthwatch.
Kieran, do you want to...
Yeah, I'll just comment briefly on the points that have been made. On Anna's point about engaging other organisations in a sense, the purpose and process of regulation, there's clearly a big shared interest there with those other organisations. And I think reflecting on our research, I don't think we've had a very good line of sight into how that's worked, because we've been pretty focused on observing the inspection process, and I think it should be happening before the inspection process and after the inspection. So it's not been perhaps a part of the process we've seen easily. But you're absolutely right that regulators often co-opt those organisations to their purposes of regulation, or try and make regulations serve those organisations' purposes, and then they use your report, for example, in leverage in local discussions. And they'll only use it if they believe it, trust it, think it's credible, and so on. So I do think that's important. We have in this work interviewed, for example, the experts by experience who are on inspection teams, and we've observed the patient-to-public engagement in inspections, for example, the listening events. But I think we've got a fairly partial view of that process from our research. On Steve's point about improvement, it's certainly true that small organisations don't necessarily have the capacity to improve. Large organisations sometimes also struggle with that capacity. But you know, the point about GP practices, I suspect, applies also to single-owner nursing homes and to quite a lot of other organisations that you regulate. It does raise a question for me, which is to what degree the inspection tells you about not just the quality of care they provide, but their capacity to improve. And so enables you to make a judgment about their likely future trajectory. Are they an organisation that is going to remain, you know, at its current level of performance because it's not capable of changing? And that's, I think, a complex question in relation to the acute trusts that you've been inspecting as much as it is to smaller organisations. And it raises the question of to what degree your inspection process touches not just on the core service areas, but on more corporate or organisational dimensions of performance, capacity to improve, leadership, and so on. Steve's other point about consistency, we are in our current piece of work, we're surveying CQC inspection team members, the staff as well as the clinicians who've joined the teams, and we're presenting them with a set of example cases and asking them to rate them. So we will have some data about consistency and reliability and rating to feed back to you in our final report. And Kay's point about the patient and public voice, I think I've answered in talking about Anna's point, that we have interviewed experts by experience, observed public engagement, but perhaps not had as much sight on that as we'd like to have in retrospect.
Michael, your machine.
Just a very few points. I also thought this was an excellent report, and there was a particular paragraph which I'll come back to in a moment, which struck me as crucial. I'm just going to work out which page it's on, because the report is not page numbered, but the chairman, David, and I attended last night a dinner organised by the Foundation Trust Network for about 8 or 9, mostly chairmen of hospitals that had been inspected. I think there was 1 or 2 CEOs. Now, this was under some form of Chatham House rules, so I'm not going to mention any individual hospitals, but the feedback to us was highly positive about virtually all aspects of the new inspection process. And as I was mentioning to Paul and Jennifer and Anna, before we started, to some extent, it's because of the how poor the old inspection regime was. So they're contrasting a previous way of inspecting, which, from what they said, sounds truly dreadful, to a vastly superior way of looking at hospitals. And so I think we have to be careful that it was really encouraging to hear the feedback, but it was partly because the feedback was so positive because what happened before was so poor. But having said all of that, the central pillars of the new process, and especially the involvement of clinicians, is the absolute key to both the credibility with which the reports are seen, but also to the impact of the reports on making improvements happen. There was actually some concern that, and this was their terminology, but I think the board, I fall into it too, that there were actually still too many old-style inspectors on the inspections. Now, David quite rightly pulled up one of the chairman around the table who had made a remark about this, to say actually the inspector he was talking about was a very good inspector, but there was, I think, a general sense that in the inspection teams there was now an even more noticeable difference in quality between the clinicians and some of the CQC inspectors. The two main points, I think, the two main learning points that came out, certainly for me, and it'd be very interesting to hear the chairman and David, was first of all some feeling that there was a disconnect between intelligent monitoring and the data packs and what actually went on during the inspection. That the inspection itself did not seem to be, although, as I've said, everybody, almost unanimously, all of these chairmen found the inspections to be extremely helpful and valuable. They didn't see a strong enough connection between data evidence and what actually then went on during the inspection, or indeed in the reports themselves. So I think this disconnect, or this perception of disconnect, is something I think the CQC needs to work on, because it does trouble the trust, and indeed I think it troubles them in a particular way, which is that we may have had a group of very good chairmen last night. I mean, they were very good, and it may have been that chairmen who were more, or chair people who were more, chairs who were more critical of the process didn't accept an invitation to the dinner, don't know. So, you know, there might have been a sort of positive adverse selection process going on. But they clearly see our reports as very powerful leverage to get change to happen. And so the quality of evidence and the connection with data and the ability to prove is critical for them, as well, of course, as for us, because it affects our credibility. The second point they made, and this really emerged throughout the evening in various shapes, at various parts of the discussion, is, and I think on page 7 of the report, in the third paragraph, which begins inspection fieldwork, there clearly was a tension last night. I don't mean a tension in a negative sense, but in an intellectual sense, between using intuition, judgment, experience, induction, and having a clear set of standards or a clear framework, as we were discussing earlier. We just need to resolve this. I mean, I don't think, I'm not going to discuss it any further. I think Mike is completely aware of this. As I say, I thought this paragraph was in a way the central paragraph of the whole report, because we have to solve this. And as I say, it did come up in various guises over and over again yesterday. And as we move into rating every hospital, and indeed other types of provider that the CQC regulates, this balance between intuition and standards will become increasingly important. So just leave that as a thought. The final point, I think, we did talk last night, and the Trust raised this issue of the patient voice or the community voice. They were actually not entirely convinced by the way the CQC was doing this at the moment. Partly because, you know, the meetings at which, or the listening meetings at which the patient or public views were being held, you know, ran the danger of having, you know, another sort of adverse selection problem, that people who had complaints would go to the meetings, but people who were satisfied didn't, or people who had serious complaints just weren't fit enough to go to the meeting. And one of the chairmen actually made a point, which I think Mike was touching on. There must be more, and he used this phrase, more sophisticated ways to get input. Now, whether that means we can ask whether the CQC itself does it, although it then becomes another cost, but using YouGov surveys or some sort of more statistically robust ways of getting the public and patient views, I think was in everybody's mind last night. It may be that, you know, we could ask the hospital to carry out this sort of, you know, a YouGov survey, and they are very, you know, almost by definition, because if they can, you know, predict the results of a by-election i.e., with a sample size of 1,000, they should be able to do a pretty good job with a relatively small sample size for a hospital or group of hospitals and various services. So, this is an important issue, but I think again, from last night, it's very important that we have to have an amount of anecdote, because I think stories are important, but it is absolutely essential in everything the CQC produces and the way it consults the public, and in all of these aspects, that they truly are based on evidence and sufficient evidence that the professional judgment can be seen to be robust. So, as I say, when the three of us left, walked out together, we were slightly overwhelmed by how positive the dinner had been. So these suggestions come in the background of a group of chairmen who found this process to be, by and large, hugely helpful, effective, and incidentally, the last question that came up was, will the inspection make a difference, a positive difference to how good your hospitals are? And again, we went round the table, and every one of the chairmen, or chairs, sorry, said yes, they will make this, at the report on us, will make a difference to the quality of service we provide. So I hope that's useful feedback on the dinner without crossing this sort of Chatham House line, whatever that is.
Thanks, Michael. I thought what I'd probably do is I'll probably circulate it as a note that I've made which takes really Michael's point and adds to it a bit. Time is getting on. Camilla, you wanted to jump in quickly on something that Michael said,
Sorry,
and then
yeah.
Mike, you want to say, and Andrea. Then I think we must move up.
Just on the YouGov point, we commission YouGov every week. They don't always predict by-elections. The most powerful way of predicting anything is actually crowdsourcing. The Friends and Family test, I would imagine, does about as well as a YouGov poll would. I guess what maybe we need is something that's more specific than Friends and Family, isn't it? So FFT gives you a generalised picture of a feeling about a hospital. Presumably, Mike, if you're wanting to get slightly below that level, and I mean, there's just a question really, maybe to think about, as to whether Friends and Family gives us, whether we're able to unpack that to a deeper level. But I personally wouldn't endorse kind of going around with a new set of polls. I'm not necessarily sure that's the right way to do it. Can I just come back to Kieran very quickly on the point about capacity, because we've discussed this before. Obviously improvement is very important to us. We're not in control of it, but we have to be cognizant of whether an organisation has the capacity. I had a meeting recently with the chairman of a hospital, which I won't name, and made this point to him because his particular hospital has serious financial difficulties. And it's the point Michael made about the leverage. He said, for goodness sake, do not use our difficulties as an excuse to prevent us from improving. CQC is the most effective lever we will have to push through the changes we need to make. So I just think that's quite important to be cognizant of. He and his board do not want us to let them off the hook because we are the people who he can use to make the change. And the final point that I wanted to ask anyway was just to check. I mean, Michael's put very well that obviously the tension that we're all aware of between what's intuitive and what's judgment and what's explicit. I just wondered, Kieran, if you could be clear about whether your next report is going to make any actual recommendations on that, or is that something that Mike and Paul are just going to sort of figure out in due course?
Just before you answer that, because I'd like you both to sort of wrap up this session. Anna, can you be really quick? And then
I'm sorry. So I just want to be clear. I think we're talking about two different things, and I'd like us to do both. And we have talked about some of this before. So one is, I think the conversation and the feedback from the dinner adds to it. Is we we really do need to have a discussion at the board about the process for public and user involvement and engagement in the round, not just about in relation to the hospital. I mean, and we've talked about this before, but I think it's increasingly, I mean, we've now got some more material, and I just think it's increasingly urgent that we have a paper to the board in the next month or two, which looks at that broad set of propositions so we can feed in all our ideas. I think the second thing is something we haven't talked about so much before, which I was talking about now, which is this business of community stakeholder involvement and engagement, which is different from public and user involvement and engagement. And that was the point I was trying to make about these people not just being useful for inputs, but also for the improvement journey afterwards. And I think we haven't really begun to think about that, and I think we should. And my third point is really just an offer, because I feel I haven't at all done justice to Camilla's question, and you must tell me, David, whether this would be useful. But we have, of course, been talking with the various inspectors about the way in which Local Health Watch could be involved in this going forward, and if it would be helpful in my next report to the board, I could do a kind of section on how we think this looks for us and Local Health Watch and what we're planning to do in the next year, so that the board could see that and comment on it.
Sense to do that. So can we agree that we'll do that, and we'll also bring a paper back to the board on user involvement? Paul, now look, Paul and Andrew both I know want to say something, so will you get it's yours.
I think mine was really just to reassure the board that although obviously this research was commissioned on the back of what's been happening in Wave 1 and Wave 2 on the acute hospitals, it provides kind of powerful learning and insight for what we're doing and developing for adult social care as well. And I think that the kind of constructs that Kieran gave us on standards of care, process and people have fed into the work that we've done. So on standards, using those that exist in terms of NICE and Social Care Institute for Excellence, but Skills for Care and National Skills Academy as well, building that into being, because the consistency issue is big for us. We're 25,000 locations and nearly 1,000 staff. Building that into the planning tool, what the lines of inquiry look like, what evidence people should be looking at, what the characteristics of good are, all of those kind of things. And very much focusing on the people side of things around co-producing the model for, between policy and the inspection teams, but also focusing on very explicit training and evaluation. And throughout our first wave, we will be making sure that we're touching base with the inspectors who are doing that on a weekly basis to make sure that that cycling of learning is happening regularly, and we will be evaluating what we're doing as well.
Thanks. So I think the question that really matters in all of this is what do we do differently as a result of what we've learned? And part of that is what we'll do differently on the inspection, but where I think we've got to is there really is a jigsaw that combines the sort of the four elements of intelligent monitoring, the ongoing relationship management with different providers, and both those are year-long, every day of the year processes, plus what happens during that week of intensive inspection, and how much more we can build up in the 6-12 week period ahead of the inspection. We really do need to get all of those things right and make sure they lock together if we're going to be confident in the way we regulate. So Kieran's report has been particularly about the process of inspection, but I don't think we can lose sight of those four. That's the one main bit. Just picking up two other bits very quickly. We haven't talked that much about the expert by experience role relative to the clinical expert role, but having been part of an inspection yesterday and on a forensic service in mental health and medium secure unit, we simply would not have picked up some of the concerns if it hadn't have been for an expert by experience who could talk in a language that was perhaps a little clearer than we are able to as inspectors in a way with people who are pretty marginalised. And he got an enormous amount of information, so I don't think we want to underplay that. And just on the friends and family test that Camilla raised, it is a powerful sense of source of information, but it falls down when it's not standardised. So the fact that we're not standardising in the way that we need to yet on the patient side or on the staff side, it's a real missed opportunity, and it's something we're in contact with other ALBs to put right.
Thanks, Paul. Sorry, David, you wanted to say something before I hand it back to Kieran and Mike.
So I think one of the key issues, I think Kieran's done a great service with the report, and Mike picks that up in the report that he published last week, many of the issues as well. And I just want to pick up on what Michael Meyer was saying that came from the dinner, though, about the importance of investing in our staff and supporting our staff to do the job we're asking them to do. I think what we're moving from is a model of inspection which is based on often single inspectors or one or two inspectors visiting large complicated organisations, to saying this isn't an individual pursuit, this is a team pursuit, and you need a blend of those skills. I think, Kieran, you made reference earlier to you need people with a background and experience in regulation, because there is a bottom line to some of this stuff. And that bottom line will be taking regulatory action. And if you don't know how to collect evidence and take a statement and take the action, then there's action that we should take that we'll fail to take, quite frankly. So there's a whole expertise that's required around that, as well as, Lewis, just to go right back to the beginning of the discussion, your point about clinical credibility, and I think Paul was touching on that in relation to yesterday in the forensics. So I think there's emphasis, and I think John might say something about this later this morning in relation to the review that they did of our readiness for the transformation, about the importance of the academy and investing in staff. And I think there's two dimensions to this. First, there is I'm not sure this is the right phrase, but bear with me, the conversion of our current inspectors as we move from a generic model to a specialist model. What are the skills that we need to equip them with? How do we support them to do that job? I include managers of inspectors in this as well, not just inspectors. And then, as Michael Meyer has reminded us on 3 or 4 board meetings, we're actually set to bring in a significant increase in the number of people joining the organisation to give us the capacity to actually undertake the job that we're asking them to undertake. And they will come from services and will need equipping with the capability to do the regulatory job. They might have the clinical expertise, but will need the capability. So there's an extended form of induction training that's required to support those people to do the job. So I think what Kieran's report does on the people aspect is actually really give emphasis to the importance of developing and growing our investment in staff and making sure that staff feel supported. I think we've talked in the past of each inspector having about 10 days away from inspecting during 14-15, so that they can be supported in learning and developing the new methodologies. And I think some of the challenges and the learning which has come out of Kieran's report need to be incorporated in those curricula so they can be taken forward. I think the other point to this, and both Andrea and Mike have spoken to this, David, is that I think the 6 points that Kieran raised around people and processes, about the issues around cost and consistency are not just about acute healthcare. They're as applicable to adult social care and primary medical services. And while the architecture around improvement might be different for all of those, this large, small, nevertheless, the legislation that gives us our responsibilities as we do this for the general purpose of encouraging improvement in services. I think the legislation is pretty clear on this. And I think this picks up on the conversation about community groups, etc., and what the leverage is in relation to that, and how we actually use that leverage to take it forward. It doesn't mean we do the improvement, but it does mean we encourage that. So I think these issues need to inform the curricula that will be an offer from the academy that will help new people coming in, or our current staff in a sense, transfer from a current model to a new model. It won't happen because we say so, it'll happen because we support them to do that. And that's really why there's an importance in investing in staff over this next period. Thanks, David.
Can I hand it, Mike and Kieran, could you particularly address this standards and intuition issue that a number of us have been raising?
Camilla raised. I hope our final report will help to give some greater certainty about that. So we'll have some data about consistency of judgment, for example, that we don't have at the moment. And it will be a longer report, which I'm sure you'll love. I think the direction of travel is pretty clear. That the plea I'd make is that as you evolve these systems, so as you, for example, start to develop more explicit standards, that we embed some work to test the reliability and consistency of those standards in the work of the teams going forward. And then when CQC is undoubtedly is challenged about how consistent your judgments are, Ofsted has had that challenge this week from the policy exchange report, you've got the data to respond. And I think that embedding of it's not really necessarily a job for researchers like me, but that embedding of that kind of evaluation of the way it works in the process is really important. I'll stop at that. Mike.
David, I'll just try and give some headline responses to a number of things that have been said. This business of capacity to improve, I think, is hugely important, but should of course be picked up within our well-led domain. And we are assessing whether I think it's a function both of leadership and culture, and because if the leadership is there, they will recognise the importance of this, and they will give it due importance, and they will have the ability to lead people through that improvement. But also, where is the culture of a hospital? In relation to Michael, what you were saying about the chair's dinner last night, hugely encouraging that it was highly positive feedback. But having said that, that's also what we've heard when we've had chief executives and others come back to us as part of our routine evaluation here within CQC, and what I've heard at other informal dinners. So that's valuable. David's already picked up on the old style inspectors. I think it is really important to remember that we hadn't given them the conversion training at the time of wave one, and I think sometimes we were expecting them to do tasks on the inspection for which perhaps they weren't suited. I think particularly the interviewing of very senior people, and I think that is where our team leaders and our chairs come in, and sometimes our board level doctors and nurses on these panels. I think it's more peer-to-peer interviewing that we need to do, and I think we are now doing. I'm slightly going to take issue with the word intuition, because I don't think it is about intuition. I think it is about how we combine hard data from surveys, from various other intelligent monitoring tool aspects, with what we see and what we hear, which is evidence in itself. It's how we combine that. And I think we've talked at the board before about how we combine 5 never events in the past with what we see and hear of has the WHO surgical checklist been fully implemented. And that is always going to be a tension. But what is important is that we recognise it as tension, that we have those debates in the amongst the team of 30 on the ground, and that we also are consistent about it across all the inspections that we do. So that's one of the things that comes to the National Quality Assurance group that I chair, and we say, well, that's not how we would have called it in a previous inspection, and we make sure try to make sure that we are consistent about that. So then the point about the adverse selection at the public and patient listening events, it can be the other way too. If people are frightened that their hospital is going to get closed, they'll turn out in their droves to support it. I think what I would just want to assure people is that we listen to those events and we use it as probes. It's not evidence on its own. We would say if all the comments have come that vascular surgery or ophthalmology is a problem area, that would drive us to look at ophthalmology or vascular surgery during the inspection. So we do take that advisedly, if you like. And I just want to echo Paul's point about standardisation of the friends and family test. That would be enormously valuable. But even within a trust, it's the variation within a trust that we can already use, because that sometimes says those are the wards we ought to go and look at. And we do use it as that. And then final comment, I think it's incredibly encouraging that the chairs were all saying yes to will this make a difference? But we need to prove it.
Was the point that Paul Corrigan was making earlier on. I think I would leave it with you, the other Paul and Mike and the other chief inspectors, of how we build in a system to evaluate the impact that we're having for the future. But Kieran, can I just thank you on behalf of us all for a really excellent, readable report that was, very perceptive and incisive. And we'll see you again when the full report comes out, I hope. Good. Thank you very much. You're very welcome to stay, but we're going to... Fine. We've got the 3 chief inspectors' reports now before coffee break. We're assuming that they've all been read. Questions for any of the 3 chief inspectors? Lewis.
Well, this is really to just to keep alive the discussion we started last time about learning disability post-Winterbourne view. So I just want to ask Andrea, I understand the responsibility is shared, but it falls most easily to Andrea, about progress post-Winterbourne view. And we had a meeting yesterday, I should say, about this, but something else happened yesterday, which is NHS England published its latest figures on how much progress has been made in response to the Concordat on Winterbourne view. So just to give you the figures from that, there are 2,577 people who are judged to be inappropriately placed. These people with learning disability and complex needs, in a sort of Winterbourne view sense. So that people with complex needs need proper packages of care and need to be somewhere else. Of that 2,577, so the commitment was to find a new placement by the 1st of June 2014. So far, of those 2,577, 260 have a date for a new placement, and of them, the date is before that target date in 172 cases. So it is 10% who have a date that would at all, and whatever the fraction is, sounds like about 7% or so who meet that commitment. Now these are people who have complex needs not being met at the moment by the current system. So there is an urgent requirement to address this. We mustn't underestimate the difficulty. I think we mustn't just say this as if it is a matter of blame. It is a difficult issue because these are people who need proper care for complex needs. And the system is trying to produce something which is often referred to as bespoke care. Now, the families of people with learning disability talk of bespoke care ironically because the truth about bespoke care is it is always the same thing. They are looking for something a little bit more sophisticated. So I raise this really to allow Andrea simply to comment and keep us alive on this issue.
Thanks, Lewis. It's very important we do keep this alive. Andrew, do you want to comment on that?
Yes, and thank you, Lewis, for the opportunity. I did touch on this briefly in my report. After our last meeting, when we discussed the 3 Lives Learning event, followed that up with yourself and with Alan Rosenbach, who sits in Paul's team, who was leading on the organisation of that. The report that I referred to will be published in May, but the discussion that we've had is to ensure that it's actually quite clear and explicit about what people are actually going to do. Because I think that what Lewis has identified is that there's been a lot of talk, there's been a lot of commitments, but actually, delivery is still wanting. So we need to make sure that we're very clear about what it is that we are already doing within CQC, what we plan and intend to do, and where we can work to influence other aspects of the system to make the improvements. But I think that Lewis has made the point, frankly, in terms of reading out those figures from NHS England, that 3 years on from Winterbourne view being identified for the shocking care that was happening there, and the attendant problems around of that, a year on in terms of today being the anniversary of Conor Sparrowhawk going into the unit where he died 107 days later, we've still got people having inappropriate services. So I think that we need to be clear about what we can do, but also be clear working with Bill Mumford, who is now the Programme Director for the Winterbourne View Joint Improvement Programme, and others, about what it is that we can do to make that difference.
Okay.
The 2 issues, they both came out of Andrea's report, but they're actually relevant to all 3 chief inspectors. And the first one is around accreditation. And I just I wasn't quite sure where we were going to go with this, because there's accreditation and there's accreditation, you know, because I guess there's the potential that if something is a service or an element of a service is accredited, then actually we could take that as evidence and maybe don't need to look at it in more detail. But then again, it might not fit our purpose. So I just wanted to kind of know and understand where we might be going with accreditation. And the other issue is every now and then I get this sort of anecdotal example of where safeguarding hasn't worked. And it seems a very variable thing. And to be honest, I'm not entirely sure how it should work. But I guess I think what our kind of emphasis probably is looking at the safeguarding arrangements of providers that we inspect. And I don't know how well we do that, because as I keep hearing examples where things seem to have gone wrong in those arrangements. And I guess I just want to know and make sure that you know, through our regulatory activities, that we make sure or hold providers to account to make sure those arrangements work, because by definition they relate to people in very vulnerable circumstances. Yeah.
Thank you very much, Kay. And if I kind of do a lead-off response, and then Stephen and Mike may want to add. On accreditation, absolutely the question that you asked is the question that we addressed at the round table that we had with providers, with people who are using services, and some of the organisations that provide that kind of accreditation, particularly in the adult social care sector. And though, as I've said in my report, opinion was split. So there were some people who were absolutely mustard keen that we should be using it, we should be reducing our duplication and effort by taking comfort from people being accredited. There were concerns raised about the potential burden on providers around, you know, yet another paper trail to be pursuing, and also a concern that might, in my sector, inappropriately benefit those larger organisations with the greater access to resources compared to smaller organisations, which might be providing very personal, person-centred, homely care, but not that which would be kind of accredited in those ways. So what we have done to date is to say that the characteristics, and we will consult on this, the characteristics of outstanding might actually demonstrate that services have accessed and used accreditation schemes, and so more of a sense of their organisations that are progressing, are embracing kind of improvement in terms of their culture, rather than necessarily saying this is a tick box that we want everybody to have, so, and that's the way that we prove that a service is good or outstanding. So it's one of those areas that our inspectors might want to look at, but we'd have to be careful about the nature of the accreditation scheme, because there's also some fantastic, you know, really well-based, you know, ones, but there's also some other ones where people have got the badge and actually it's doesn't mean a great deal. On safeguarding, you're absolutely right to say that what we need to be doing is assessing that the arrangements that providers have in place around safeguarding are appropriate. It's absolutely clear and explicit in the questions that we're asking, certainly in the adult social care sector. And we have also been doing some work, and that's the royal we, because it was actually Bill Hodson, our National Professional Advisor on Social Care, who's been leading on this, doing some work on defining the roles and responsibilities of the different bits of the system in safeguarding, and that's something that we've seen at the executive team, and is going through the other organisations, including NHS organisations as well, so that we can be clear about what that picture is.
Just on the accreditation point, we've been doing some work within the Hospitals Directorate looking at what the criteria should be for us accepting accreditation programs, and I won't get them all right, but they include clearly are the criteria used evidence-based, has there been strong clinical engagement, has there been patient involvement in developing the accreditation program, what is the inspection program itself like, what are the intervals between inspections, but importantly importantly for us, what's the fit with our 5 key questions? And I think that's something that actually it would be useful if the 3 of us saw if we could have a united view on that. But my view is that there are some accreditation programs we will be able to accept really very quickly, and that those will then cover areas of the hospital, or indeed mental health in particular, actually, where we may not otherwise be able to do it. And Paul Elliott, one of the Deputy Chief Inspectors, has got a great deal of experience in accreditation and peer review, and he is leading for me on that.
Just a comment on child safeguarding, because that sits under my new directorate, and it's just to say that we're taking it very seriously. The new deputy who starts in April, Sue McMillan, has this under her wing. We've reviewed the team which sits across primary and secondary care and increased the number of people involved, and also just recruited a head of across children's safeguarding and health and justice. And Sue has already started to have meetings with other chief inspectors, including work with Ofsted and HMI prisons.
Thanks. Good reports. Thank you to all 3. Just 2 points I think relate to all 3. The first one is about our role in influencing the information authorities to get the data we need. I was really struck by an interesting thing that Steve wrote in his report about out-of-hours services being a data desert. No doubt that does also apply to community, but the pressure that we are putting on the National Information Board to set the priorities for data collection, I think, is a question. And the second issue was Mike's lovely report, and I noticed you've been out giving messages, which is good, which is great, but it leads back to the previous conversation about support in the system, and I wondered whether or not we should be, if we're not already, thinking about what messages we can give to the sector, particularly boards, with TDA and Monitor, on 10 big things we've learnt this year, for example, on governance or well-ledness. I don't know whether that's in the plan, but it doesn't stray into us improving, but it does stray into us providing some easy support. You know, what are the 10 things we think boards should be doing as a result of our collective intelligence during the year? Wouldn't cost much, I don't think, to do that, but it's just a suggestion on communications.
Yeah, so thank you. On data, data is just essential, and it also, it's not just the information, I can't remember the new word, a National Centre for Information. It's also bodies should provide, like CCG's, information we need in a timely manner, and that's been a struggle so far, still is a struggle. I want to make 2 statements, really. One is I support the care.data concept. I'm really sad that it hasn't moved forward, because I believe it'll have really important implications for improving healthcare research, but also the work we're doing, which is on behalf of the public. And I think it's, I'm dismayed that it's been delayed, and I understand why they came to that decision. The second thing is just to echo Paul's point earlier on about the friends and family test. If you're going to bring in requirements on trusts or surgeries, you should standardise it so that you can compare. And I just don't understand why they're not doing that. And it seems blindingly obvious to me on both. But there you go.
Yes, in terms of data, one of the key things that we need to press for is for information to continue to be collected at a hospital or location level, not at a trust level, because if we want to be able to say what is the maternity service at Newham or Whipps Cross or the Royal London like individually, which is what the public want to know, we've got to be able to have the data related to the individual locations, not the whole of the trust. So we are making that case. I think surveys and making sure that surveys are up to date, and so that we don't back off from saying, okay, we'll do this once every 3 years. Actually, that's not useful to us. If we want to be able to look at A&E or maternity or whatever, we really need data that is within the past year. And I think the third element, following up on what Steve was saying on care.data, I think the key point I would make there is everybody is exhorting us to look at pathways. Well, it's care.data that will help us to look at pathways. And so every time that somebody says pathways, then let's look at care.data. And then the final point, which also builds on something Paul said earlier, is the effectiveness domain requires national comparative audits if we're really going to look at that seriously. And as a country, we invest very little at the moment in national comparative audits.
Best practice, you know, where trusts are doing well.
The 10 big things we've learned.
Yeah.
Yes, I think what I would like to do is, you know, we went cautiously because we were basing that first report just on 18 trusts. But I think by, you know, by the time a year has gone past, we will have done 50 or more trusts. And I think at that point, we really will have more solid evidence on the things we've learned. And I'm sure we should come out with our statements, because I think we are in a very privileged position of seeing what hospital care is like, and ultimately I think we will do the same in other sectors.
Camilla, then I think we'll break for coffee, if that's all right. Yeah.
Two quick points. I really agree with you, Andrea, about accreditation. I think you're right to be suspicious of it. Personally, I think there are a number of schemes in social care which really don't stack up. I think there's a lot of people making money out of it, and I would really hope that one of the things our rating system will do is actually shed some light on the validity of those schemes. So I would be really worried if we were going to take most of them as read, because I don't think that's our job is surely to do make our own judgment. I don't know, I suspect the ones in the NHS are slightly better, but I just think we need to make our own judgment. If the other accreditation schemes support that, then all well and good, but I think we need to be a bit wary about taking them on site. The other point, I know I've made this before, and it's never terribly popular. On the data point, of course, we need the best possible data, and we need it in real time and so on. I do wish that we could also just be cognizant, particularly in social care, about the burden that we are placing on individual providers. And obviously some of the discussion, you mentioned that, Andrea, when you talked about the worry of the small providers have that the bigger ones have an advantage. Later on we're going to discuss the large amounts of money we're going to put into reviews. I do think we ought to consider whether we could just have some sort of look at what burden does CQC place, particularly on small social care providers. What is the reality for the person, the registered manager who is sitting in that office? How many pieces of paper do they have to produce? How many phone calls do they have to make? I just think it would be, in terms of our overall mission that we've discussed, we're trying to be supportive as well as, we're trying to be friend and foe. I think it would send a very positive signal if CQC showed that it was cognizant that we are putting a big burden.
Thank you very much. And one of the things that we're doing in the Wave 1 and the Wave 2 inspections is asking providers for an information return in advance, and there's two reasons for that. One, because actually the standard data across our sector is nowhere near as good as other sectors. And also to actually try and help to be more efficient on the day that we turn up. I've gone in inspections and you knock on the door and the registered manager goes, oh my dear, okay, and I'm scurrying around kind of putting together all the bits of paper that the inspector's asking for. And so what we're trying to do is to bring some of that a bit further forward. But as part of the evaluation, we are asking the providers to tell us how long it took them to complete that form, how easy was it? Was there anything that we were asking for that they could have provided to us in a different way? Was there anything that they thought that we shouldn't have been asking for? Or other information that they could have pointed us to that actually could have done that better? So I think it's kind of part of our commitment in the co-production is to be working with the providers to do that with them in the best possible way. And it'll be a really important part of our learning in Wave 1 and Wave 2 to try and do that as efficiently and effectively as possible from both our points of view.
Thanks. Don't give up on that message. We need to be reminded about that all the time. Good. Thanks very much. I think we'll break for coffee for 10 minutes. Thank you. Let's kick off. Just welcome Rebecca Lloyd-Jones, who I think most of you know, who's sitting next to Mike, who's our head of legal, and I thought it'd be useful to have her here while we have this discussion about the appeals policy. Paul, you're going to kick it off.
Thanks, David. As part of getting ready for the early April provider handbooks publication for consultation, we absolutely want to make sure we understand our journey on appeals, and that needs to cover the full gamut of judgments that we make. It's worth saying, as the first paragraph of the paper sets out, that the law has an escalation to tribunal process for certain parts of our judgments, registrations, and then conditions and cancellation of registration. But for the areas that are around reports and warning notices and the ratings themselves, that's covered by a separate part and isn't covered by the tribunals. So it's all the more important that we do have an appeals mechanism in place. In looking through this, what we've been careful to do is to say there's clearly a long process that we discussed earlier in the board meeting that goes right through the way in which the inspection is conducted, whether there's factual accuracy, representations on the warning notices, all the way through to a rating. And what we don't want to create is a system where there's a great deal of duplication. So we want providers to have an opportunity to appeal against different elements, but in the right way. So, for example, at the moment we have factual accuracy representations being made on reports, and that we think should absolutely continue. But we wouldn't want to get to the stage where then the separate appeal on the rating, which is what we're talking about in this paper, would then go back to essentially a second round of the same issue on factual accuracy. So we're being quite clear in the way we want to delineate that. The second point is to say that with the regulations underpinning the Care Bill, if it becomes a Care Act, those regulations come in, including the regulations on ratings, most likely in October. So we're using the intervening period very much to learn as we go. So what this paper is proposing is an approach post-October. However, we would want to learn and test it and review it pre-October. The board is asked for two things. First is to approve the overall proposal for appeals, but specifically this element about independent reviewers as part of the appeals process. And there, what we're trying to be clear about is that in law we can't and shouldn't outsource the decision-making process. That's not appropriate or right, but we absolutely do want to have the right level of independence modelled on some of the other regulators, so that if there is a concern or appeal raised by a provider, it is demonstrable that we have looked at that and independently had a view on whether there's a merit in that appeal before it goes back to the chief inspectors and the chief executive as part of CQC. We think the way to do that is to have more than one independent reviewer. We're thinking about a system where we might have two independent reviewers and, for example, a deputy chief executive, deputy chief inspector looking at the appeal, so there's a majority lay or independent. So that's one aspect we're asking for board's view on. The second is just a more general question for board advice on how to ensure that the appeals process is sufficiently transparent and accessible.
Thanks, Paul. Hang on. I'll come to you, John. Rebecca, did you want to comment at all, or do you just want to listen for the time being?
No, I'm happy listening, but obviously if there are legal questions, then I'm very happy to answer them.
John.
Thank you. I was glad to read that Rebecca had been involved in writing this report, because it is absolutely vital that we get the legalities of this right if it's going to be sustainable in the future. I've got two questions. The first question is whether, as I understand it, this system is an advisory appeal. In other words, somebody appeals to it. The appeal people, the court or the tribunal, whatever it's called, comes to the panel comes to a judgment, which then is advisory on the chief inspector. And I want to know whether we looked at the alternative, which is an internal process where the CQC, if you like, reviews its decision and makes its own judgment, which is then the decision. Because I think there may be some confusion about what happens when an appeal is made. The appeal panel recommends a course of action, but the chief inspector decides on balance that he or she is not going to accept that. That may then cause consequential issues. And my second question is whether this process has been costed, and if so, whether the cost could be approximately declared, and is it, perhaps more importantly, in our budget?
So on the first, it is exactly as you describe it, as advisory, but with a strong expectation that the chief inspectors would take on that advice unless there was a clear reason not to do so. We did look as an exec team at a number of different options, including an internal process. We absolutely felt that we needed that level of independence. It won't stop us from also looking at any appeal on its merits internally, and what I suspect will happen in the sort of normal discourse with the provider is there will be concerns raised more informally before a formal appeal, which gives us an opportunity to look at those. That's on the first point, John. On the second point on costing, I think, try to be clear in the paper, it is very difficult to cost this because we don't know the volume. So we've tried to give some very initial estimates, which I think are absolutely at the top end on sort of day rates, very much dependent on who the independent reviewers are. But this is one of the main reasons why we want to test the process pre-October, so we get an understanding in the budget, understanding of the likely costs, and we can make sure they're covered.
Yeah, I mean, obviously we need this process, but if we were getting lots of appeals that were upheld, there'd obviously be something wrong with what we're doing. So, almost by definition, that we would really only expect to have, if everything was working properly, a few appeals. What I was wondering, I mean, is it likely that there could be speculative appeals? You know, that, well, I might as well appeal just in case, and that will be very expensive. And and I just wondered, is there a way that we could offset that in some way? And I mean, one thing that occurred to me is whether people had to pay when they appealed. But I know that could be sort of controversial. But it's this issue of we'll appeal just in case because there's nothing to lose. Yeah.
Point. Eileen, did you want to comment on that point?
David, just to really invite Rebecca to contribute, because we have to be very, very clear about the grounds on which you are able to make an appeal. And they are actually very limited, importantly limited, but whilst we can't actually anticipate how many people will take up those numbers, and Rebecca will explain what those grounds are, I think it's right to anticipate in startup phase you'll have many people thinking it is worth a go, and as the process settles down you'll pull back to quite a small level of activity would be my anticipation, which is why the model outlined in here has got quite a high degree of flexibility attached to it in terms of the cost base, so it's not about building a huge appeals secretariat either. But if we asked Rebecca perhaps to just outline what the grounds for appeal could be, I think that would be helpful.
Well, you're right that we are clear that by the time you get to appeal your rating, you will have had the chance to dispute and make representations about all the evidence. So it's not a question of reviewing the evidence base, it's a question of reviewing how CQC's applied its own process in terms of the allocation of the rating in our sort of proposed grid. So it's a much more administrative review, not an evidence-based review. And I think there will be a spike initially because people will want to test it out. But that's the same as any time when a whole tranche of new laws introduced. There's always a sort of period of it bedding down. But in the longer term, I think the numbers would diminish. And I think we would have a filter mechanism where, you know, cases were looked at on the papers, and if they aren't making out their appeal on the right grounds, we'd send them back.
So kind of following on from that same point, because I agree there'll be a spike and it should decline, but one of the ways in which I think it will decline, it will be one of the influences on that rate of decline actually I think is about the transparency around the process. So I mean, the question in here is about having the appellant at the hearing, and I think if I was thinking about this from the user perspective, I would always argue yes, and so kind of logic requires that I say the same in this case. They should be able to hear the reasons which are being given directly from those who are considering them, in my view. But I also think there's something about doing some learning reports from the appeals that have been heard, particularly in the early days, so that there's some kind of feedback to the regulated community about what the basis for successful appeals and the basis for unsuccessful appeals. So there's some learning built into the system which will help to support that decline. And I think we should also and we'd need to think about whether that's on a named basis or whether it's on a kind of general lessons basis. But anyway, I think that's something we should want to commit to. And finally, I think we should signal that over time, as we get a handle on how this process is used, we might wish to identify what we might describe as vexatious appeals, because I think it should be in our gift to refuse to hear an appeal if we consider it to be vexatious. Now, what that would be going forward, I don't know, and we won't know for some time, so we need a bit of kind of case history to learn, but that we would want to do that in due course, I think is an important thing to signal.
The process looks good to me and pragmatic. I just wanted to ask whether Ofsted not only have the independent advisors, but they also they give their advice internally to the organisation at the same level that we're suggesting, i.e. to a deputy inspector, and then that goes to an inspector. So in other words, where does the independent advice go in Ofsted? Does it go to the board, does it go to the chief executive, or does it go to the equivalent of a deputy chief inspector, was question number one. And question number two, people can appeal, or at least against our assessments at the report stage, as discussed here, but also there's a bit upstream where they can also start to question. And it's not based on the evidence, but it's based on judgments on the evidence, which is where we are very implicit still, as we've just discussed. So it's at the stage where we feed back to the trust before we've actually got a written report, that actually it's the judgments that is the problem, and it's to keep a handle on that, because if we don't get the appeals right, then the balloon will squeeze, and in fact people might start appealing earlier. If you say this about our trust, we will call in the lawyers kind of discussion. So it's making sure that bit is closed off as well, or at least it's consistent with our.
I'll have to get back to you out of the meeting on exactly where in the Ofsted chain it goes to, or unless Paul knows. He has knowledge of Ofsted. No, okay. I absolutely agree with you. Because our appeals will be both on the process of aggregating the ratings, but also on the making of the rating, individual rating judgment, that balloon squeezing can happen.
So it's tracking where we are being. It's also tracking where we are being challenged before the report. I think there will be, because obviously we've had some publicised pieces in the HSJ about where we have been, whether that's correct or not, about where we've been challenged at that point.
So I think this is a really important point, and this came out in the dinner last night, to go back to this dinner, where the majority of the chairs there raised an issue about the initial feedback, and I think we've either not emphasised or they've not heard this is initial. They've seen it as being definitive, and therefore they've raised this issue about, well, what does the report then go on to say, which is the space that you're referring to, I think, Jennifer. Interestingly, the group that were there last night were of the view that, well, don't do the initial feedback. And at least one of them did have the opinion that actually they need the official feedback. To leave this for weeks and not know what a view is would be just too much for people to bear. But I think it does play to the point that we need to be really clear. This is initial feedback. The reason it's initial, as Mike has said on a number of occasions, is that the unannounced component to our inspection is likely to take place after that initial feedback, and therefore we're not completed in our assessment of the trust. And notwithstanding the point about whether we ask for too much data or not, very often if we ask for additional data, it's not there during the course of the inspection, and therefore we actually want that data coming back to us to arrive at a firm view. So we do need, I think, to reflect further on exactly that point about what we do say initial feedback and what we do say in the report. And I think that's what we were trying to get in the section on page 2 between what can be challenged in the reports and what can be challenged in the warning notice, as distinct from what's on page 3, which is what's challengeable about the rating, whereas in a sense the rating challenge is a process challenge in effect. It's did we follow due process, as distinct from did you agree with the judgment. It's not a rehearing of the evidence that allows people to actually pressure to make a different rating. So I do think what this paper is trying to do, I think, Jennifer, is be really clear about what is it that people can make representations about and what weight we should be giving to that, and how can we ensure that by the time we get to issuing a rating, we've followed our own processes and the way that we've got to that judgment is entirely consistent. There's not a logical gap in the way that we've actually arrived at our view.
Very important we're clear about that, because at the moment there is a kind of street view that we buckle if we are threatened with legal action before we've produced our judgment. I don't think it's a widespread view, but it's certainly in the undercurrents.
Is it worth me just saying something about that, David? So in wave 1, there were I heard 2 representations against warning notices. I will not say where they were. And in those representations, in considering those, one of the questions that we explored, and I did this through conversation with others, one of the issues that we explored was if we were saying in place X, the failure not to use the WHO checklist, it warrants a warning notice. What did we say in places A, B, C, D, E, F, G? I can't do it. How many does that get? What's 18? But anyway, have we done the same in all of those? And the answer to that was no, we hadn't. So I didn't uphold that representation. I upheld the representation because I couldn't guarantee the consistency of the approach. So it's helpful that you've asked a question that we can now go on public record that the issue there was not backing off because somebody said, we'll threaten you, was that we couldn't guarantee consistency. Both Mike and Kieran in their reports have raised this issue about consistency. What we're determined to do is ensure that in wave 2, and certainly by the full rollout from April onwards, that we are consistent in that. I know we've, consistency has been a theme this morning. So we will do that. And I'd personally like to scotch the rumour that we backed off because there was a big beast that threatened us. We actually said, in the spirit of wave 1 and 2 being about open learning, that what we didn't have is confidence that we'd been consistent enough. Kieran said that to us, Mike said that in our own evaluation, and that's the issue, I think. So I'd hope that there's not just a subcurrent about this, but that can be a debate. We will be looking for that consistency. The standardisation conversation we've just had reaches to this. and being clear about the evidence we collect and then the judgments we make and being consistent about it is a real issue. Those first 18 were a real, and we've made a virtue of this, and I don't think we should be defensive about it whatsoever, whereas 1 and 2 were about learning and doing. I think Kay used that phrase earlier about learning through doing, and that's exactly what we've been doing.
I very much take on board Kay's point, and it really raises the question, which was touched on last night, about whether in fact there should be an appeals process, or whether if the CQC, if a provider disagrees so strongly with the CQC's rating and thinks they have grounds to go to a judicial review, well, so be it, but that the act of having an appeals process means that people will start appealing, and they could appeal, as Kay pointed out, in large numbers, because we're not here just talking about acute hospitals, but of course all providers that the CQC rates, which it will be doing over the next 18 months. So I think there is almost a question before this paper, which is, or before one thinks about the paper, should we have an appeals process, or should our stance be, we're an evidence-based organisation which makes highly professional judgments with great integrity, and if you think there's legal grounds for disagreeing, that's up to you, but that we take this quite tough line about the quality of the judgments and the ratings that we give, and don't have this appeals process, which, as I say, I think Kay correctly said, could open the floodgates. So I'm in a way challenging the basic assumption here, which is, we need an appeals process. And certainly last night there was, as I said, I think David, I think it's fair to say there was pretty close to unanimity about don't get into the appeals space. This is, it will take you down a track which you really don't want to be down at all.
That is absolutely the case. This is a big point, so I don't want to lose this point, but Camilla, do you just want to add to that, or...?
I was really going to make the same point. I think, and what I was going to say, I started from exactly where Kay started from on this. I just thought this is going to become a sort of badge of honour for people to say that they've, managed an appeal. And I totally agree with Michael. I think what would be very useful is to see some kind of cost-benefit analysis. Part of the argument in this paper is financial. I think the rates being suggested for independent reviewers are frankly astonishing. But it would be interesting to see some, I know it's hard to know, but it'd be interesting to sort of estimate the cost of judicial review versus the potential cost of this. At the moment, I don't have a feel for that, as to how big this could get. But essentially, I agree with Michael.
I think that Michael's argument is a very interesting and seductive one. And I'm not sure that one should not, I'm not sure we should come to a definitive conclusion on this without following Camilla's advice, which is really to weigh up some of the pros and cons of doing it and not doing it. And I think one of the things that distinguishes this paper is it's a one solution paper, and doesn't set out the thought process about the options that faced the authors. That's not a criticism, it's merely to reflect, I think, on where we are. I would say on the experience of the CQC on the old inspection system, which when it was first created, as I understand it, I wasn't around at the time, had all sorts of failures and so on, but there wasn't an appeal system. And one of the things that it generated was a large number of complaints. It did have a complaint system. And that complaint system, what happened to it was it got clogged up with complaints from providers about the way that the inspection had been carried out. It was in fact being used as a surrogate appeals mechanism. So just by not having a review system or an appeal system, and I think there are choices about those, doesn't mean that the only option is judicial review. One might find that all sorts of other systems that exist are then hijacked to let off the steam in the system. And that's, because of that, is why I support Camilla's point about really looking at this and saying these are the options and the costs and risks associated with them.
It's interesting that last night they made a big distinction between escalation, being able to raise it within CQC at a higher level, as distinct from an independent appeal system. But this needs, I think, this needs some more thought, Paul, I think, and the three chief inspectors. Can we take on board the comments and give it some thought over the next 4 weeks? Paul?
We will absolutely do that. We do want to put something in the handbooks, and bear in mind the handbooks are published on April the 9th, and very much in the spirit of consulting and asking for views on this. So we want to have more of that public discourse. So it'd be helpful to know if we have the board's seal or not to put anything in the handbooks on appeals. I think there is also a line that's, the question is probably for Rebecca, around the specifics on how costly JRs get. But my understanding is that there's a question of whether we just should or shouldn't, from some sort of sense of expectation of the sector or moral obligation to have an appeals process. That's one thing. But my understanding is there's also a link between, if it did go to JR, the process we had or hadn't followed in having an appeal could have a bearing on the success of the judicial review, which Rebecca is the expert on that.
I mean, are we not can't we pose the question in the consultation, rather than saying this is what we want to do, what do you think? Why don't we could pose the question?
Absolutely we can, but we also are conscious that we are rating all Wave 2 providers in the acute space. So between now and October there will be a whole series of ratings out there, and that will be followed in due course by all the other sectors. So it's a live issue for us whether we have a level of independence, which is what we want to test. So I think we should pose the question openly, but also be open that we are intending to test a process pre-October.
Sorry, what I'm concerned about is if we put it out there, as it were. I mean, this is a decision for us. This is not a decision for providers. This is a decision for us to make about what is right and what we can defend and so on. My only worry is if we put it out there, we create an expectation, and even this discussion isn't making it entirely clear. I mean, obviously, none of us would argue that we shouldn't have a proper process for people to come back and question any facts that we've got wrong, any inaccuracies, all that. There is a proper process for that. What we're discussing is whether you can appeal against what is essentially a judgment. And obviously, one of the most important things about our new model is that it is not just a tick box exercise. It does contain judgment, which is where it then can become difficult to defend in certain situations. My worry about putting it out there before we've agreed it is simply that if we then decide not to do it, the headline becomes CQC rejects appeals, which would not be correct, because it's not that we're not allowing people to appeal against various things. It's that we wouldn't be allowing an appeals process against other things. You know what I mean? I'm just concerned about how that might be seen at a superficial level outside the organisation.
I don't know whether, Rebecca, you could ask Paul's last point as to whether or not, in order to obviate a judicial review going against us, we need to have an independent appeals process. I don't know the answer to that. Do you know the answer to that?
I can have a go. Our thinking is that the Care Bill doesn't set up an appeal mechanism, and the bill is compatible with the Human Rights Act as it stands. So it would be possible to proceed and simply rely on judicial review as the legal remedy. That would be an option. However, the more that we can demonstrate that we've dealt robustly and constructively with people's concerns about our application of our internal processes before it reaches that stage, the the less ground there is to litigate over. So, you know, we can give more thought to the cost-benefit analysis, but I think what doesn't get dealt with one way will get dealt with another way. I mean, there might be some people that don't want to go ahead in JR, but there'll be plenty that do. So when they go and seek their legal advice, if they're told, well, actually, this CQC process is a good one, there wouldn't be much less in terms of the space for them to challenge us. So that was the thinking.
I mean, this is likely to come to a head firstly in the hospitals area, because that's the area where we are rating from now onwards. And a particular issue in the hospitals area is that at the moment I am chairing the National Quality Advisory Group, so I have seen all of these proposed ratings as they're coming through from hospitals, so I may not be in an independent position to to deal with an appeal, which in effect means it would have to be another member of the executive if we were to do it internally, if we were to treat it as we do representations, which we certainly could do, but that would probably mean it either lands up on one of the other chief inspectors' doors or on David's door or Paul's, and I think that is something that we just need to have a process for how we would handle representations about hospital ratings. We need to have that sooner rather than later. I mean, we might want to put something round to board members to think about that even before the provider handbook comes out, because I think we're in that space almost from now.
Just worth learning from the Audit Commission here, because they obviously had a CPA, which is the assessment of performance of local authorities, a much more tense space. Chief executives losing their jobs, and indeed the politicians in local government being judged by an internal inspector, and therefore their capacity to be re-elected was affected. Audit Commission managed it. They had an independent appeals process, and as a result, very few things went to JR, actually, very few things in local government. And from memory, the Audit Commission won practically all of them because of the criteria that were very astutely crafted at the very beginning. So I think there's precedent here, isn't there? I mean,
in health and care, both CSCI and the Healthcare Commission rated, and the CSCI one then populated the Audit Commission, and there were legal challenges JR has taken against both the Audit Commission for accepting CSCI's judgment, and that fell because of the process that was there which allowed that appeal. And the fact that it was documented and clearly documented meant that they were consumed internally without going externally, and the cost and the time that goes with that. And we touched earlier about the undercurrents, that all of that is transparent. There's a process that people can see and observe, etc., etc. So I think I think when this, and I take John's point that there's a one option here. So we started with a premise that a good public sector body does have a way of people making representations against its judgments, and therefore what is that? And the appeal is not against the judgment, that's ours, but against the process by which we got to the judgment. And actually leaving that space for people to come back to us against the process against the judgment is really what we were trying to get here. So we weren't retreating from the space of this is our judgment. But we were saying there needs to be an opportunity for people to come back to us where they think we've got the process wrong. So where we've got rules, the handbook, and we've not followed those rules, and we've said it's X, Y, or Z, or A in terms of our judgment, that there's an opportunity for people to say, oh yes, but you haven't followed your rules. I think the point earlier in the paper is both accuracy on the report, they can come back on that and say, well actually you said there were 12 staff on duty, and here's a rota, here's a pay bill, there were 20 staff on duty that evening, so that becomes a matter of factual accuracy in the reports. There's representations on the warning notices. There were only 12 on duty. We want to take a warning notice in relation to this, and if the warning notice doesn't stack up because the evidence is wrong, it doesn't compare, going back to the earlier story in relation to the wave one, then actually we've got a process for dealing with that. So your point, I think, earlier, Jennifer, we just need to make sure that we've got all those opportunities covered between the report and the warning notice. So that then left the judgment. And on the basis this is our judgment and we shouldn't retreat from that, then what people have got is an opportunity to say you haven't followed your process. And I think where we got to with Rebecca's help was that that then means that the gaming, I think, that you were referring to, Kay, that people will do it because, hey, what is there to lose in relation to this? And that was a feature for both CSCI and the Audit Commission, in my view, is actually what were you doing is you were removing the opportunity for game by just being really clear about what the appeal was for and what the rules are that people could follow. The risk, I think, in my view, colleagues, is that if we don't have some rules for that, we'll just create a great big playing field for people to play on. And I think what we're trying to do is say, actually, we need to demonstrate we're fair. It was one of the things that came out in the conversation with Kieran, and this is a way of actually just getting some element of fairness in the process without retreating from what our formal and from when the Care Act as royal assent, our statutory responsibility is to rate services. So that's what we were trying to do in that, if that helps. And as I say, Jennifer's reference back to the Audit Commission and our predecessor bodies that rated, then I think is very, very helpful history to actually inform the decisions that we actually need to make. I think Paul's point about we do need to settle this for the handbooks is not to force people into a decision that they feel uncomfortable with, but I think Mike's is even more expedient that we're going to rate all the wave 2 and we need to send some signal, although that's under the old legislation, not the new legislation, of how we're going to deal with this. So the timing of this is it's a pressing issue that we need to be clear for the handbooks, but actually it's having some principles by which we can actually deal with wave 2 coming forward is also what we're attempting to do here. So we can take it away and do more work, but I think I would ask that we can send a signal in the handbooks about what we're trying to do.
Just ask Paul Corrigan, do you have a view on this? You've got to press your button. Press the button, Paul, if you have a view. That I'm sure you do.
No, I think the predecessor bodies and the Audit Commission managed a very, very contested terrain really well, and in a way which, as Jennifer was saying, there was politics involved as well as people's careers, and people who were involved in that in local government accepted it. So I think if they manage that terrain, that political terrain well, I think there must be lessons for us from there. And if they had an appeals procedure, I think it would be dangerous not to.
I'm beginning to think that this title I was given of Friend or Foe was the most astute thing that I've come across for some time. I think we do have to think how this would look to people out there if we have no... I mean, I think I rather enjoyed Michael's argument, I must say, but I'm not sure I agree with it in the end because I just cannot see how we can look like we are friend, not foe. To concerned clinicians, concerned patients, if we are not prepared to consider where we get it wrong, we get the facts wrong, or we get our process, we don't do what we say we would do. So on those two grounds, that we made a mistake, we didn't get the detail right, we misjudged what was going on, we've got to have some way of letting people come back to us on that, and or that we didn't do what we said we would do. We've got to have some way for people to come back and tell us that. So on those two principles, which I think I understand as the basis of what's being proposed, I would broadly support it, and broadly support going ahead with whatever we need to say publicly, even if it's couched in consultative terms. I think we can afford to say that these are the principles we're trying to get right, and this is where this takes us to at the moment. And of course, we're prepared to consider people's views about that.
I mean, I think that's where I am. I must say I hadn't thought about this enough until Michael and others have raised the issue about, and Kay and others, whether there should be an appeal. But I think I'm where Lewis is. Is that I know it's not. Is that the general consensus? We should go on that basis, that there is that narrow appeal around process to an independent party, or do people feel very strongly that we shouldn't do that?
I think we should go ahead on the very narrow. I think we should go ahead and make it clear that it's a very narrow basis.
Okay.
Personally, having listened to everyone. But
And raise the issue about whether there should be an appeal process in the consultation as well.
Yeah. I mean, David, if I may, I mean, you know, our strategy kind of said that we wanted to build better relationships with those we regulate, and I think that, you know, that is one of the overarching strategic priorities that we've got. Being absolutely clear about how we're going to do it will help, but I think that there is something about us being I think it's sufficiently confident, to come back to one of the points that Camilla was making, to say we should open ourselves up to that appeal process on the basis that actually, you know, it will help us to learn if necessary. It will help us to demonstrate that we have actually followed our process if that's the appropriate outcome. But it also means that as a public body, we are open to that scrutiny in a way that I think actually helps build confidence and credibility in what we do. So I'm as guilty as anybody of kind of thinking, yep, we should just get on and do it, and it's about how we do it, rather than kind of taking you through the thought process of getting us there. But again, other public bodies and my experience back at NICE in terms of having an appeal process around that was also very instructive to me in terms of my influence on this.
Just a quick point. There's a thread that runs through a lot of the papers this morning, which is about our overall communications messages and strategy. And I wonder whether at some point, it's an appropriate point, we might just have some time on what are our overall messages for us as an organisation going forward on a range of issues.
David, sorry, very quickly. I mean, I support a process of review of it being challenged by within a system which is within our involves us rather than going externally directly to the court. What I'm uncertain about is whether that should be an internal review or an external review or an appeal, because this isn't an appeal, this is just a review of the case. And that's my uncertainty about it. But if we need to start the process of explaining that, A, we wish to be challenged ourselves rather than saying you're on your own, go off to the court, and that we are trying a system, then I'm happy to go along with what's proposed.
Go ahead on the basis. This is the presumption is that we carry on this basis, but it is a rebuttable presumption, and we can come back to this, can't we, before October, in the light of what we hear from people or our own views.
Well, we absolutely will, not least when we come back with the response from the consultations around the provider handbooks.
Okay. Can we have the last word from Michael?
Yeah, well, I don't want to have the last word, but the section in the handbook for acute care is very specific about the appeals process. You know, it says, you know, it has, you know, within 10 days, within 14 days, and so on. You know, it's so detailed that it almost feels like this isn't a consultation. We are going to have an appeals process, and we know what it's going to be down to the last day in which you could make the appeal. So I think the consultation needs to make the appeals less specific and more general. But I think it should also stress, which it does, but because there is the appeals section, that there are these other very important steps in challenging the CQC. I mean, the one that David has just mentioned, is the sheer accuracy of the information we've used versus the information a hospital or a trust may have, and then the ability to challenge a warning notice. So there's lots of challenge in the system, and I think it probably in the consultation paper, I don't want to sort of try and sway this to my thinking, but I think, if it was possible, then, but you could argue this is too biased. The consultation question could be, and I'm not trying to word it exactly now, but as the CQC is completely open to challenge on factual evidence and on warning notices, should there be a further appeals process? Again, I am biased. I'm leading the witness here, but I think we've got that. But I think we're happy to be led. I think.
Yeah. Let's look at exactly what the consultation question is. We will circulate that. On the details that are in the very, very draft version of the acute handbook that you've seen, I think those numbers are very much a provoke thought rather than any sense of them being the right numbers. And if it's inappropriate from the purpose of this conversation, we can absolutely take them out, but they certainly shouldn't be seen as any signal to the system.
Thanks very much. That's very helpful. Paul, yours is the next item as well, thematic topics.
Thanks.
Rebecca, thank you very much. You can stay if you wish, but you've got... No.
So last month, we brought a proposal for the process around selecting thematics for 14-15, which the board endorsed with comments. And at the same time endorse the approach of having up to 4 large thematic reviews and up to 12 smaller thematics, but very much in the spirit that they had to really add value. And we talked about a sort of 2.5% to 3% operational resource implication of that, up to, and again, I think the central theme of the work we've done since then is this has to be manageable within the workload of our inspectors. We can't trade, so we don't have a comprehensive inspection process. So this paper then sets out the suggested list of thematic reviews, both smaller and larger, but very much for discussion with the board. It's worth just drawing out 3 or 4 points. Firstly, that we, again, in a previous board meeting, 5 thematics have already been endorsed for 14-15, and those are brought out on the first page. Some of those are pretty big pieces of work, for example, on end-of-life care and on dementia care. The second part is to say that if the board's view is that we should have more rather than fewer thematics from the list or from additional ones that you think we should consider, then it may be that we need to come back and say, well, we're looking at the resource implications in the round alongside our ongoing inspection activity. There is only a certain number that we can do of these in 14-15, in which case we propose that we have a pipeline process, that we put the ones that are lower on the priority list but board feels are still important in the pipeline, keep a careful eye on whether the world moves on or not, but always come back to those as we're planning our 15-16 thematic programme. The page 2 of the paper you have just sets out the selection process, and if I just finish with 2 points, one is to say, to kind of give information that there were 31 thematics that were considered on the long list and don't make it into this paper, just to give you a sort of sense of the large number of ideas that were brought forward, and that's following a reasonable sort of consultational, well, informal engagement exercise, including with members of the board. And finally, as it sets out in the paper, there are 2 thematics where there is a public commitment to do them already. So unless the board feels very strongly, I think we'd expect to do those.
Thank you very much, Paul. Any comments for Paul? Okay.
Yeah, 2 things. Just to seek sort of reassurance or assurance that we have the sort of capacity and capability to deliver all of these, because I know David Behan said that we're running hot. So just to, be clear that we can actually deliver these and deliver them well. The other thing was we often get asked to give examples of good practice. Can you point us to somewhere that's doing complaints well, or is there somewhere that involves patients well? And I just wondered if the sort of good practice bit was sufficiently prominent in some of these reviews, because sometimes it's simply we give examples, and maybe that's okay. But I just feel, given that we encourage improvement and given we're looking at it more in depth, I mean, we could even have consider a review that is actually looking at good practice of a particular issue. I mean, the one thing that springs to mind to me is, for example, around how well providers engage and support staff. What organisations do that well, and how do they do it well? Because that I believe there's sort of evidence to suggest that where staff are engaged and supported, it has a really big impact on the quality of care. So that actually could be quite a significant way that we could, influence good quality care.
Yeah, I feel a bit guilty about this because, first of all, I have a feeling I must have missed a phase in this consultation because I don't remember seeing the 31 topics, although I did see a list of topics which I commented on. But maybe I'm saying I may have missed them. I'm not saying that in a sarcastic way. I'm genuinely saying I may have missed them. But that's important because I don't recognise where quite a few of these topics have come from. And to me, this list, this is why I feel guilty, because I'm afraid what I'm going to say will sound rather critical, and it may sound like criticism that we've gone over previously. But it does highlight for me where we're not absolutely sure yet what the thematic reviews are quite for. And not only that, but what people are expected to do with them. And so I do feel that the list is slightly still reflecting that because it is a bit of a mixed bag of things which sound so huge that they are almost the entire work of CQC, like how safe is care? That sounds like more than a thematic review to me. And then there are some very specific points which I suppose sound more doable, more manageable, maybe more worth the expenditure. So I'm a little bit unsure how we got to this point. I'm a bit doubtful about some of the examples, and I'm still a little bit unclear what we will be able to do when we have got the answer to the review. And just, if I could just say one thing, just to give a couple of examples there. The one on depression, I suppose, is the one that I think I know most about. The question it will answer is, how well is depression recognised in different parts of the community sector? The answer is not very well recognised. So I can save us an enormous amount of money by doing that review myself. But there could be a question about how well the sort of much lauded psychological therapy services, which when I was working with the Department of Health I was partly instrumental in setting up, but how well they've really done what we thought they were going to do. Now that's a much more specific question about a nature of care delivery. It's a more modern question because it's about a recent development. It crosses the sectors because they were specifically designed, these services, to cross primary, secondary care boundaries. And to tell you the truth, it's also reflecting quite a lot of criticism in the field of those services. So it's answering a question which people are raising a lot of, but where there's not a huge amount of evidence. So there could be a one on depression, but it would be a much more focused one. I must say I rather like the idea of complaints or something like complaints being a topic, because but I would give it a slightly different emphasis, and it comes back to the question I asked you once before, Paul, which was whether we were in a position ever to develop a sort of science of complaints. Because otherwise we're in danger of thinking complaints are important, but not knowing exactly in what way to turn them into usable information. And doing a bit of practical field work, which might include looking at good practice in individual settings, on how complaints can be turned into, because complaints are often free-ranging, they come from some people but not others, how they are turned into a more balanced consideration of a service, how they become more objective, more scientific, I suppose. So there is a possible, quite specific topic about complaints, but it might not be the one that we've set out at the moment. I won't go on, but we talked about medicine management in care homes. That's not on the list. That seems very important to me. Maybe it's somewhere else, but that does cross two sectors. And there's one on looking at the 7 steps from the NPSA. That feels a bit old-fashioned. That's an old piece of suggestion to the service, looking back over how well that was implemented some time ago may not be the top priority, I would say. So again, can I apologise for sounding so critical, but just felt, where is this taking us?
It's really helpful, actually. Should we just come back to you, Paul, at the end? So should we, Jennifer?
I thought that the objectives for the thematic activity, which are on page 2, were good ones, and I remember discussing those. So I think that's pretty clear. And the 2 further selection criteria, I think, were also good. I'm agnostic about the actual list. I think some of it looks quite sensible, and well, it does look sensible, and the questions could be rephrased, such as how could depression be better recognised? That could be a very more specific question. But and the only thing I would say is, from experience, less is more here. So there's only a certain number that the service can digest. So err on the side of parsimony, and I think we can debate the actual precise topics, but I think it's clear to me anyway. Thank you.
So when I looked at this paper, I read it and then I moved on thinking, how the hell does a board make this decision? And that's because I recognise that the criteria, which are the filters you'd already put it through, they've worked, because we've got some things which are they'd be very interesting. But then I got to, but they didn't tell me which ones to do, and we could all choose our favourites, but that's not the way to do it, is it? So then I got to the business plan paper, and we've got our 9 areas of focus in the business priorities. For the business plan for this year, and I think it's really important that we keep ourselves focused on those in the next year. We've got so much on our plate that it seems to me that anything we do in thematic space needs to play very strongly into the work in the business plan. And while all of these could do in some way, that it seemed to me anyway that 1 or 2 of them did much more clearly. Now, I could identify those. I'd pick complaints and whistleblowing. It appears in priority 1 in the business plan. It's there loud and clear. And there's another one on integration, which is a bigger project, which isn't as well defined and probably needs a lot more work, because it fits into Lewis's category of kind of, the world and everything. But again, that's very much there in priority 4, and we don't really know how to do this in inspection space. So I think my question back to the senior team is, these all look fine, the process looks good, but which of these will help us to deliver the business plan in this year? Or will help most to deliver the business plan in this year? Because that seems to me the basis on which we should be making the decision.
Any other questions? Paul, do you want to... Paul and Camilla, then the other Paul.
This is something I'd not thought about until Kay said about best practice, and it links in with things that have been running through a lot of what we said today, which is how do institutions improve themselves? And there's lots and lots of examples of good practice around that no one takes any notice of at all, and it seems to be not very useful to add to that list. But on the other hand, we would have a lot of information about the conditions under which institutions do institute practice from outside, because that's what we'll be picking up through inspections. Some will be saying, we got this idea from X. And so it will be interesting to know not just where good practice is, but what are the conditions under which that good practice can be implemented. And that could, so on page 2, when it says encourages improvement, it seems to me part of what we need to start doing is find the conditions under which organisations can improve, and we could do this in any of these topics. And so it seems to me it's not just what is a piece of good practice, but why do some organisations do this and some organisations not? Because then that becomes part of well-led. Okay.
Yeah, I thought the criteria are very good, and we've agreed them before. I'm not sure that all of these actually meet our criteria, and particularly on the question of why CQC. I mean, without going through the list, I would like to see a much more extensive explanation of why. There are in most of these cases, there are a number of other organisations that have already done work in this field, are doing work in this field. It's not costing us money for them to do it. the question then becomes, are we an aggregator of other people's data, or are we adding something unique? And on a number of these, it is not clear to me whether we are or whether we're not. And I just wondered, I mean, I think Lewis and Jennifer have both made the point, we need to really tightly define the question. I mean, you know, when you write you're absolutely clear in the way you write the question as to what the impact is. And I think when I see something that says how well, I'm always kind of slightly losing the will to live. I mean, on the integration point, you know, there is so much work going on already on that. I just would really like to be convinced as to how we are going to add. And it may be that we need to be more aware of what's out there, but I'm not quite sure how we're going to add. Just on, I mean, I wondered whether one way through this, and it's back to what Lewis was saying, I mean, I just wonder whether each one of these almost needs to have a board sponsor or the chief executive sponsor. I mean, I sort of feel that I'd like to see one of us just making the case, you know, when we've got down to our shortlist and really saying, okay, why are we going to do this and nobody else? I just sort of feel I haven't had that experience, and I think if you've got people around the table with incredible expertise in certain areas, is this the way we can leverage that? I don't know. Otherwise, it seems a little bit divorced from. And there are individuals around the table who have particular passions which, you know, might be of interest. And I don't know whether that's a way through this, but I just think we need to be a bit more rigorous about whether it's meeting what we set out to do.
Well, would you like to respond to the various comments that have been made?
Absolutely. Okay. So if I go through them in order, and I'll try and do it at a pace, but absolutely not in a glib way. So apologies if I take a little bit more time. Okay, you started. I think your two questions. The first one was about whether, given how hot we're running, we actually have the capacity to do this. No, I think it's too difficult to say. Sorry, on your first question, Kay, I think it's too difficult to say definitively we have the right capacity, and that's not least because in most of our sectors we're going to be learning in the first half of 2014-15 just what it really takes to inspect. That's the process of wave 1 and wave 2, and that's why we want to have this buffer of a pipeline. So we want to be able to come back to the board and say, for the ones that you prioritise, this is what we can achieve. Realistically, we're not going to be doing much actual work on the ground on these new ones in the first half of 14-15. We'll be doing lots of work on the 5 that are in the paper and already agreed, because we'll be much more in the scoping and design phase. So we can run those two processes in parallel. Are we setting out the good practice? I think it's a great challenge. So I think implicitly I had the view that yes, we would always do it, but I think the way to do that is to say every single thematic needs to systematically in a structured way say, both to your point, what is the good practice we're seeing, and to Paul's point, what are the conditions in which it's being implemented, and why would we believe other people can learn from it? Lewis, on your points, no, you absolutely didn't miss a step in the process. The process we ran was to ask for everybody's views, but we didn't include in the process, to be honest about it, then feeding back all 31. I can absolutely share them, as well as the numbers that have been included for discussion here. But there was no step in the process that you missed. I think you're right that some are very big and some are more contained, and depression was a good example of it. A lot of people have raised, for any individual one, there are people with a great deal of expertise, and we could probably give you the answer. I think being able to give the answer with a specificity on region by region or sub-regionally, and also the conditions in which it's positive or successful or not, and which aspects is probably where we want to focus more on the thematic. But the key point for me is that some of these really deliberately aren't tightly scoped. When we have for 50, there's a limit to how much detailed scoping we could do on all of these, given all the other work we're doing. We much more wanted to come with this as the areas. We're under a statutory duty to come back to the board with the scope of any Section 48 report, when all these thematics will be done under Section 48 of the Act. And so we would come back to the board in one form or another to test the exact scope, and key in that will be the exact question, but also the design and methodology of the approach. On the science of complaints, there is certainly one of the thematics does look at complaints outside of acutes. It is only outside of acutes because we're already doing so much work in the acute sector, particularly on this. And on the 7 steps, The reason we included it was because the view from our safety experts within CQC was that was, so it was 10 years ago, but it was an extremely important piece of guidance, which is relevant today as much as it was 10 years ago. And the concern is that why basic things like root cause analysis are not being effectively carried out in the system. And to understand a bit to Paul's point, why is it that this good practice isn't actually always landing? So it wasn't just to say, did something happen or not? It was to say, if we think this really was right all along, why wasn't it? Why hasn't it been systematically done? Jennifer, yeah, less is more is also, I think, good for all of us as on the exec team. We would rather be able to do the things we do well. I mean, that's a statement of the obvious at one level, but in terms of what we put in the pipeline, if we can do it versus what we actually do, we want to apply that principle. Paul, I think on your comment about the conditions of best practice, that's sort of like picked up in this way in which we do a structured thematic that looks at good practice and how. Camille, on your why, whether the why CQC has been is the right organisation to do the piece of work. You're right. When I look at the scoring criterion, there are some that score more highly on that one and less. That's absolutely right. I guess the question is that they had to be above a certain bar, but it's the right challenge. If somebody else could do this equally as well as us, then we surely should kick it out. I personally like the idea of board sponsorship of individual thematics. I think it's better placed once you've selected the ones to do, and that could then sit alongside the fact that we want to have a joint ownership within the CQC that's operational as well as the policy people both owning these pieces of work. And I think that would only be strengthened by having a board member who was responsible. Probably more about that side of it than individual board members saying, this is the one I want us to do because of all the, the challenges that brings.
Thanks, Paul. I don't feel that we're really comfortable in this area yet, Paul, to be honest with you. I think it just doesn't feel hard enough. I mean, I quite like Camilla's idea of someone's got to have a real passion for what we're doing and why we're doing it. It's a bit like going to a sweet shop. And I sort of feel that we're picking out lots of different packets of sweets at the moment, and we should be focusing on the gobstoppers. We should be focusing on something that we really want. It just, and that's how. Do you feel the same, or do you?
So, you might shoot me now, but if I could make a suggestion. So I think the point about connecting this to the business plan is very powerful. I think this issue about what's worrying people out in services about whether this stuff is working, and then this point about what works and what doesn't work and what do we know. And I just wonder on the topics that are there, whether there's a way of actually becoming more comfortable by doing, the learning by doing model. In which case, and I think the idea of a board sponsor, of somebody who will actually give some support, encouragement and challenge and passion for it, I think is, with Paul, I think is a really good idea in relation to this. If any of that works, David, then what I think the report is inviting the board to do is consider a 2 and a 4. You don't have to do 2 and 4, coming back to the running hot and the resources issue. I can't believe we're not going to get through this year without somebody having another idea about something we might have a careful look at. So building headroom in here.
Paul's idea is a really good idea.
Yeah.
The kind of organisations that do adapt things from the outside. Yeah.
So where I was going to go with that, sorry, I was going to give you an offer about we might shape some of them. I think Jennifer wants to come in.
Just to say, it's a great point about context. We've just done a review of this, and actually the results are pretty boring in a sense, because it's the same things come up every time: leadership, culture, all that kind of thing, and it's often very difficult to distinguish between different services, different issues. It's the same set of internal context ingredients. That we've just published something. I'll send it to you.
But I mean, Kay raised complaints, for example. I mean, that's a very specific. We could look at best practice, the best hospitals that deal with complaints, how they deal with them.
So where I'd go then with this is, I think Lewis is reframing the depression one about what do we know about psychological therapies. Why has it been given traction in some places and not in others? And we might have said that before, but there seems to be a fundamental issue about the impact on people in communities, whether you've got access to that or not. And that might be one to look at. I think the issue about trying to anticipate the future, it seems to me that the approach to the development of acute healthcare is predicated on the back of building up community-based services across health, primary care and community healthcare. And I think the proposition about vulnerable people might speak to that, and we could say something intelligent that I'm not sure who is saying something about that. There's lots of people saying what it should be, but I'm not sure anybody is actually saying this is the reality of being old and living in Blackburn. So I've just covered in my comments was number 2 and number 4, yeah. I think then just picking up on what other colleagues have said in relation to the shorter ones. Go on. I'm trying to give a way to have a conversation that allows us to either walk out of here saying we're not doing any, or we're walking out of here, this is what we're doing. And I'm trying to get us to that. Or, you know, if you don't want us to do any, then I think that would be a shame personally, because my view is if we want our state of care report to be authoritative and say something, then actually this is the evidence that we need to collect to get to that. I think the contribution colleagues have made this morning in terms of what they would want it to be on why do some things work and others don't, what is the lived reality of some people using new services, how prepared are we for a major investment in community healthcare services, which is actually predicated on the back of a whole strategy, it strikes me, in terms of for acute healthcare. Seem to me to be important things that we might want to give comment on, but if we do want to comment on that, we need to collect the evidence, otherwise we end up being a polemic organisation which is making commentary on things based on I'm not sure what. So if we're going to get the evidence to comment on, then our inspections are part of that evidence, but the evidence from inspections by themselves will not answer some of the questions that have been provoked by this. So I think the list is an attempt. And you're right, David, I think we need to go to a greater sense of confidence and maturity about selecting these, but at the minute this is where we are in relation to them. And I think from what colleagues were saying, I think there probably are 2 longer pieces of work I would offer, Camilla. It's a suggestion, it's not I'm not trying to lead you at all. I'm certainly not in Michael's position of leading the witness on this. But I think Lewis's challenge on the depression one was, I have to say, it was great. And I have skin in this game as well, because I was a civil servant that led the rollout of psychological therapies. So we've both got skin in the game. But actually knowing has it made a difference might not be a bad question to answer. And if it has made a difference, where and why has it made a difference? And if it hasn't, where and why has it not made a difference? I think the points about consistency with a business plan probably would take us into complaints and whistleblowing, notwithstanding the work that Michael's leading. I think the issue about safety could actually be a direct lift, and notwithstanding your point that maybe we know about this, but if safety is really the feature of the way that healthcare and care system needs to operate, what do those 7 steps mean? Is there something in there? So it might not be just about safety, but actually Paul's question about why do some things work and other things not work. So what I'm offering, David, is that a way of actually just trying to go through that list and actually come up with some work here that might inform the state of care.
I think the board, we're not against doing thematic reviews, and we've set out the criteria under which we will assess thematic reviews. I think it's probably a mistake to bring lots of them here. Actually, I think we want the 2 or 3 that you've worked up in some detail, and if it was depression, for example, so that we could then tailor it more. I think that's what we're looking for.
Okay.
Because otherwise we're all going to have anyway, Michael and then Jennifer. Then we better move on.
It's just a quick point. You know, we've now completed the Wave 1 hospital inspections, and Wave 2 is underway. There was a very strong theme running across Wave 1, which is A&E services were almost universally a problem in every hospital inspected. And with that, the CQC is therefore building an experience base in A&E, which I wonder whether that should be a thematic review, because we really are the only people who have that extent of knowledge. And if we can do a review which then says what best practice is and how to get there, I think that could be very powerful. So I think that is a sort of a thematic review that draws directly from the results of our inspection process. Now, it's too early for adult social care and primary care because we haven't started the new approach, but where we have, there's already this very powerful issue emerging. But I don't know enough about healthcare. Maybe that Camilla will, tell me, because I just don't know, that there are X numbers of people looking at how to solve A&E. I don't know, but we certainly know a lot about it now.
And we will have done an out-of-hours review, which actually means you've got urgent care and A&E. We'll have done 2 parts of this.
At risk of opening things up, I'll try not to too much. I see the potential value in 2 areas. One, those things that no one chief inspector's area can do, so that's the cross-cutting element which is built in, and the other is doing what in clinical language would be a phase 2 trial before a phase 3 trial, looking at a particular area, but not across the whole country, because that could then influence how we go about our full inspection program. And if we learn things about nutrition, for example, as we've done in the past, that could potentially influence how we then do all our inspections. That's where I would hope that we might add value.
Right, I think we'd better move on. We haven't come to a conclusion on this. I don't feel, Paul, that we're quite where we need to be on thematic inspections. The conversation is we're just not we're not all in the same place on this at all at the moment. So I'm afraid, suggest that we rethink this a bit and bring back another paper to the board in a month's time.
Can I make an ask?
Can you what?
An ask of that paper?
Yeah.
That there is a clear and limited recommendation from the executive about what will make the biggest and best contribution that CQC can make, given everything else that we're doing, both in terms of our own business planning and in terms of the major issues that we've identified. Because I just feel we've had conversation, we've opened up the list, we've created a basket full of treasures. And every time we talk about it, we add more, and we will always have that tendency to do it. We've given you some really clear criteria, which I think we all rather like, even if we're not sure that they've absolutely been applied in every case, about how we want you to select. We've given you some more guidance today about how we'd like you to do it. And I just don't think this larger group of people is the place then to choose which ones to do.
That's where I am as well, Paul. Can we... Go on.
I was just going to say, I'll bring you a list saying this is what we're going to do next month.
And this is what it's... Yeah. And why?
Yeah.
And why?
No. It's great as this, David.
Why? It's the impact.
No. It's a really helpful conversation, a genuinely very helpful conversation, and it's added to the previous 2 conversations that we've had on this. And I think what we'll bring you is a list of what we're proposing to do and why, and when we begin. And I think these challenges about why us and nobody else, are we duplicating what others have done, how does it fit with a business plan, are helpful additional points that we'll draw out, and we'll bring that, and we'll bring you a defined list of things that we'll bring forward to do.
Okay, thanks very much. Paul, yours is the next paper as well. You've still got the energy.
With a due sense of trepidation. Okay, so this looks at our intelligent monitoring, but not the acute side where we probably have more board conversations to date, and at a number of the other major sectors, so adult social care, primary medical services, both in hours and out of hours, mental health services and community health services. Can I just start by framing what we see intelligent monitoring as, only because I've noticed it's become synonymous with this banding process and and almost in the eyes of the media, but absolutely not in the eyes of CQC, some sort of proxy for rating. It absolutely isn't that. As Mike said earlier, it serves a useful purpose in guiding where we should inspect. And that's on the banding side. But it is also the wider process by which we use all the data available to give the best view on where risk is in the system for all those days when we are not on site, which of course is the vast majority, and that's its real power. So the question we've been asking ourselves is, what level of specificity can we go to in the different sectors outside acutes? We think there's no sector where we can't produce useful analysis, intelligence to guide our inspection judgment, just to put that out there. Clearly in some sectors the data is less and in some it's more, but there is always enough to guide inspection. The question that follows from that is there sufficient data to accurately band, for the purposes of inspection, the level of risk, the priority for inspection. And this very much plays to Jennifer's question earlier about volatility in the acute intelligent monitoring. And we've had to ask ourselves the hard question: if we were to produce a banding in, say, adult social care, would the knowledge that it gave us of where to go next be outweighed by the number of false positives and false negatives that would bring? That's really the question that the analyst team, led by Lisa Annerly, has been grappling with. So where we've come out to is that there is sufficient accuracy and standardisation of data for the in-hours GP component, the primary medical services component, but not for out-of-hours. And there is sufficient in mental health, but there isn't sufficient data in adult social care, either residential or domiciliary care. And there isn't sufficient information in community health services. So if I sort of translate that, that would mean that there would be a banding for inspection that would cover GPs in hours and would cover mental health as well as in acutes, but not for the other sectors. That's our proposal. And the board is asked to agree the direction that we've laid out.
Thanks very much, Paul. Any questions for Paul on this?
I wondered if you considered things, for example, the sort of financial situation that in a particular area, or where there are sort of major reconfigurations, because that often kind of it can generate sort of pressure on services and a dip in quality. These are very sort of specific indicators about the service or the hospital. And I just wondered if they're sort of wider, if there are cuts, for example, that's going to impact on the quality of care, or, an organisation being in debt, or major changes.
Yes, to split that into two, I think there's the specific question of the sort of finances within a particular provider, as an example. And if I just go back for a second to the acute, so only because we'll follow the same broad approach. Both Monitor and TDA do obviously produce judgments on sustainability, including the finances of providers, and we do look at that as part of intelligent monitoring. But I think the second part of and there's no reason why we shouldn't also do that for other sectors. For the kind of the question of, is a particular local health and care community particularly stressed or challenged? We haven't tried to do that in the quantitative data associated with intelligent monitoring, but we absolutely are trying to set that up through the sort of the ongoing provider management, relationship management that I mentioned as one of the components of the jigsaw earlier. And we're looking to develop more of a sort of a local understanding of what's really going on to inform that. What I don't think it'll be is easy to standardise. I don't think we'll be easily able to compare, because it's just extremely difficult, and everyone gets tied up in knots about whether the allocation in a particular area is sufficient or not. But I think we can say there simply is a big reconfiguration of services going on, like about to go on in, for example, the Stafford region. We would need to therefore look carefully at the the quality of care as a result of that, so we can follow up on that.
Good, thank you, Paul. Is that it? We move on? Jennifer?
Sorry, it looks very sensible. The only thing is a sort of repeat of a comment made earlier, which is about, are we in a position to produce any kind of roadmap as to when we think some of the data that aren't available could become on stream? It's working with the information board.
Yes, so we are absolutely doing that work. I'm not sure, I'm not in a position to say, therefore, sector by sector, where things will come in, but two specific points. So we lead as an organisation for the whole of the health and social care system on the roadmap for unlocking the different data assets, and I'm sure there is a better way of putting that, that Tom Ward in our organisation leads on with Emma Rourke. And we could bring back a paper actually on that. We've already produced papers for the National Information Board on that, and we could bring back a paper to our board on what that looks like. Separately, Emma Rourke and myself and one or two others met with Tim Kelsey and his team last week or the week before last, precisely to look at what we could do between our two organisations, NHS England and CQC, to just drive forward this agenda of what data is missing sector by sector. And what I was pleased with that conversation was just how much of it was about adult social care. So it wasn't, even though NHS England has a particular locus over the NHS, they weren't forgetting the importance of the care data as well.
Our assessment of risk in different sectors by inspection should help to drive the priorities of the data. So in other words, we're the only organisation that can see the quality through inspection.
Yeah, that's exactly right. And it's why, Steve made the point about care.data earlier. Having that data that's linked across primary and secondary care, and in the full care.data vision includes adult social care, as my understanding, is just incredibly important, so we can get a better understanding on risk.
Right, thank you, Paul. Is it very quick, Lewis? We're running behind.
Okay. Well, I think this is probably about as good as it could be at the moment, I suppose, my initial thought. There is a slight sense in which the last conversation does apply here too, though, so I just want to miss that entirely. That no. But don't worry, I'm not going to go through each indicator in turn and pass a judgment on it. But there is a sense in which we are always, and for years this has been true across the NHS, that we start out by wanting to know the answer to certain things, and we end up looking to see what answers are available, and that determines what questions we then ask. And that is it's still a little bit like that. And I don't think you could necessarily do any better than that, but there is still a slight sense that the indicators are a sort of composite of what's available, and you're fairly explicit, that's true. So I think there is a version of this which will be slightly more strategic, maybe reflecting our 5 questions a little bit more clearly, being clear where each of these indicators lines up along with one of the 5 questions, and then making it clear where the gaps are that would need to be filled before this process over a few years would be completely satisfactory. And for example, you could say effectiveness is not very obvious. Our service is effective. It's not so obvious, but you've got some ideas about clinical audits. You could equally say NICE guidance and its implementation. So there are ways of signalling where this needs to get to in order to be a better overall picture.
Okay. Yeah, and that I think is absolutely right, Louis. So when we're on 3.1 in the paper, although we tend to dwell much more on the top bit of that pyramid, which is the data that's already there, and therefore it means we can use it and use it in a comparable way. The whole point of us having that tier 3 indicators, that's the full set of indicators that don't even exist. It's the ones that we would want lined up against our 5 domains, and which we want to work with the system to create. So we're constantly prosecuting this, what's the data we really can use for banding purposes or for informing our inspectors of things to look at the same time. This goes to Jennifer's question about looking to develop where the data that isn't currently available should be.
Right, thanks very much, Paul. Thank you. The next paper is on fees consultation, which is you and Eileen.
I think everyone will want to hear from Eileen.
Well, Paul is too kind, as usual. either by incredibly intelligent design or very happy accident, we seem to have a bit of a theme going here today, which is about the value proposition of the CQC and what we bring to the world. And this brings it in part to summation around what we expect people to contribute towards funding that value proposition. I think the paper, I hope the paper outlines what has been quite a lengthy and challenging process for us to get to the point of recommendation to you today, which we would ideally really like to conclude today in terms of the cycle of our business process. We realise it's rather late, but I think that's because some of the challenges inbuilt in getting to this position. And also to say we're also mindful that for the coming year we want it to be a process that engages you earlier, gives you a sense of fees and how we approach them in the wider funding area regime for CQC. So that process is actually beginning now with a view to engaging you in late summer or early autumn in quite substantial discussion about that. So if I just set the scene there, and I'm sure Paul and I would be only too happy to take questions from you on what's put before you. Paul in particular, I say, nodding at him over there.
Thanks, Eileen. John, you probably have a question on this.
I have quite a lot of questions, but I'm not going to bore you with all of them, and be glad to know. I think the feature that most worried me was the differential recovery rate for different sectors. In other words, we are basing our fees on the costs to us of inspecting those particular services, and those costs are vary quite considerably, from 39% of the actual costs for independent healthcare single speciality services up to 100% for primary dental services, although we're recommending that be discounted, and also for adult social care. And I just wonder how sustainable that process is in the longer term. I think clearly it would be far too disruptive and delaying to try and unpick that now. But I do think for the longer term, it will reopen the issue that I've experienced in the past from different providers saying, why is it that our fees are calculated on a different basis from other sectors? The NHS is being given a softer ride or a harder ride or whatever it is, and vice versa, traded comments. Now, there are a number of complicating factors about all of this. One is that some of this data is possibly questionable in its accuracy, and therefore it's probably unwise to place too much reliance on it. And secondly, these changes need to take place over a longer term. But my plea would be that, as well as doing this on an annual basis, there does seem, in my view, to be a need for a longer-term harmonisation. And in particular, I find it difficult to justify, or I have found it difficult to justify, why a private hospital should be charged on a different calculated rate from an NHS hospital. I mean, that's the obvious trade-off. Single service facilities are, I think, a special case wherever they are in the system. But there are some anomalies, and I think that at some point it does need to be a longer-term calculation about how those anomalies are removed from the system. I will leave all the rest of my questions in abeyance.
Thanks very much, John. I think that is something we must pick up in the autumn. We look at this more carefully. Are people happy with the recommendation that's come out?
Just to make the point, I mean, I'm sure a lot of work's gone into this. I think we should recognise as a board that this is very difficult times for all these providers, and that it is a big ask to increase our fees. And I think we should be cognisant of that, and we should, as a result, be committing even more strenuously to offering value for money in what we do.
Agreed.
Can I just perhaps do offer reassurance, Camilla? We have a very, very strong drive to be thinking very hard about what the cost of delivery is in each and every one of these areas, and therefore what is the value proposition that we bring, what is a reasonable recovery rate against each sector, and to have enough evidence to do that sensibly.
I think, Jennifer, Camilla's point, it is against a background when, if you take the adult social care sector, for example. I mean, they are being squeezed and squeezed and squeezed. It's really, I mean, and the same for the NHS as well, but it is very, very, very tough. That's the point you're making, isn't it, really? It's really tough, yeah. Jen?
This is just a strategy discussion sort of issue, but I think we've got to address this issue in our strategic plan. That what's our long-term game plan? Given the squeeze is going to be on for 10 years. We're in the sunny uplands of funding as far as the CQC is concerned, and we can't stay there. So how are we going to squeeze back in the longer term? And what messaging we give out now before in the next year?
Yeah.
I was just going to make the point that sort of links into the next item, that in terms of the uplift we're expecting from the fees, it's approximately 2 to 3 million more from the provider sector, and in comparison, the indicative uplift that we are expecting from grant in aid, so from the Department of Health and through from the taxpayer, is 40 million. So just to give a sense of, as we produce our we look to do things differently and better, the burden of which, additional burden we're placing on individual providers through the fee structure is vastly less than the amount that the taxpayer is picking up through the Department of Health grant and aid.
So, small point, but kind of on the back of that, which is that I think it's really important equally from the political perspective that it's clear that we're not using the uplift in funds to finance the reduction in income from providers. So I think the £800,000 that we need to find to finance this change in the fees needs to be extra to everything else in the budget, just as this is a change in the budget plan for income from providers. And I know it's a small amount of money, but I just think it's a principle that is really important, so it increases our efficiency challenge immediately, and then we need to do more as well.
David?
So we don't have to find £800,000. What we'll have is an operating budget next year of the income plus the grant in aid, and that's what will be distributed. So we just need to be quite careful. A plan of what we hope we would get is not the same of what we have been given, and then actually allocating what we have been given across our budgets is what we'll do. So so I'm giving you comfort on the main point that you're making. I think on the substantive point about where we're going in the future, the conversations have already begun with the Department of Health as part of this year's grant in aid settlement about what next year is going to look like. And the point about both value, Camilla, that you're making, and this issue about where does this policy of full cost recovery lead us to, because in effect what we've got is we've got a policy for the, if I can use this phrase, the old model of inspection, not for the new model of inspection, and so it dramatically needs reviewing. So we've got something which is both consistent with the approach that we're taking, but also, as you say, with the forecast for the next few years in relation to what the reality of that is going to be. So all those things are part of what we're actually currently taking forward.
Okay. Good, thanks very much. Business plan, Paul.
Thanks. So there's been a previous conversation at board about this draft plan, and we're now asking for agreement to publish the plan as it stands, and as Annex A. We've reflected the comments from the board, which is on page 4, showing those. So, for example, the consistency check that was brought up between the 3-year strategy and the 2-year business plan. Business plan very much reflects the fact that 14-15 is a transition year for us, one where in a number of sectors a significant amount of our regulation will take place against the old model as we phase in the new model, and of course with the regulations underpinning the Care Bill and potentially the Care Act coming in midway through the year. But it's the plan itself is seeking to set out, as you know, the overall objectives, but then the strategic measures and the operational KPIs and the risks, and set out what we expect our budget to be, accepting that we haven't signed on the dotted line, as it were, but the numbers are the 103 million plus 120 million, so 223 million on revenue and 15 million on capital. That's our planning assumption underpinning the business plan.
Thank you, Paul. Anyone got any issues they want to raise with the business plan? Jennifer, then Kay.
Just a small point on priority 6. I wonder if we can just increase the profile of our idea about identifying and spreading, identifying good practice, good examples. I mean, it's kind of there, but it's to really bring it out a bit.
We'll do that.
Okay.
Yeah, I mean, the business plan, from my perspective, is fine, but it does need to feed into our new performance framework, and it would be helpful to have a sort of update and reassurance that where we are with the new performance framework, and to know that, within that, it will cover the business plan, so we know, how well we're doing and are we delivering it.
Yeah, again, we can bring that back. There's various pieces of work ongoing there, some of which were brought to the Regulatory Governance and Values Subcommittee yesterday, covering the improved way of looking at regulatory risk and assurance. We can certainly bring back how the whole business plan and that piece and our sort of quality framework knit together.
Good, thank you, Paul. Any other questions? No. Right. We got to performance, Paul. It's still you, I'm afraid.
I'm sorry. Okay. So, this is January's performance and finance report. Although, where we can, we've updated it with the latest information. If I, rather than try and go through it in detail, if I just draw people's attention to section 2, the notable performance, and just that piece in bold, I think is the main bit to draw out, that as of the 14th of March, CQC has completed its entire inspection programme. So that's just under 3 weeks ahead of the year end. And I think this sort of congratulations should go to all our inspection staff, but also supported by National Customer Services Centre and Intelligence and our engagement people and our operational performance improvement people, our oppos. That's quite a different position than the one we were on last year and in previous years. The issues where we are off track are, I don't think, news to board members. That's the reports within 25 days and registrations and variations of registrations. In both those cases, I think the underlying issues are well understood. In registrations, it really is the increase in volume, and in terms of the reporting, it's about the complexity, particularly in NHS Trust reports. And on that second one, we're looking, therefore, to set different and more graduated KPIs for the 14-15 year, which are in the business plan. The focus now in the remaining couple of weeks before the start of the new year, the new financial year, is very much on operational readiness, which Hilary Reynolds is overseeing from the exec point of view. And if I just briefly recap the finances, we are predicting a £2.3 million revenue underspend and a £7.7 million capital underspend. That's consistent with the previous reports in the last few months. And the reason for that, as we've discussed before, is that we are spending what's necessary and appropriate and no more, given that it's taxpayers' money and provider money. And that as we go into the planning for 14-15 with the department, we're being very careful with them to say, particularly on capital, this is our best view at the moment, but as our views develop and our plans solidify, we'll want to keep having that conversation rather than getting into the sense that, we'll just bid for the most and then account for why we didn't spend it.
Thanks, Paul. Any comments on performance? I just think we all ought to just note the fantastic work that the inspectors have done and all the people who support the inspectors in getting these inspections done at a time when all this change has been going on. It's been terrific, really. So easy to have slipped. And they're done, and they're ahead of schedule. It's fantastic.
I think it's fact we planned to finish in week 49 and we finished in week 49.
David, you've said one of the things I was going to say, so I won't repeat that. Paul has said what I was going to draw attention to on the money, but there's one question which hasn't been answered yet, and it's on page 4 of the reports, and it's again a feature, if I can make a more general point, it's a feature of these reports which I hope will change in the future, which is that they tend to report activity rather than achievement. And it is the paper reports that 774 locations have had a warning notice served on them, which is an interesting piece of information, but enforcement is simply a means to an end. And I'm much more interested in what the end of this, so are there 774 people who've now complied with the warning notice, or is it 774 minus some figure? And could we have, if possible, an indication of what that, the product of the sum actually just turned out to be?
So we will overhaul the report for the next financial year, and we can say more about what the impact of those warning notices has been.
Can you just remind us, is it the next board meeting that we'll get the new version of this? I thought it was this today, but it's not, is it? Because the year end is March 31st, isn't it?
Yeah. I think we probably won't have the new one because we won't be able to report anything new for 14-15 for the April board.
Okay, but in terms of the financial summary, we will be getting a much more detailed summary, won't we?
Yes. So the full end year summary will come. This definitely doesn't include it.
The point Camilla's making is that when we go into the new financial year, the monthly financial reports to the board will be much more detailed than they have been in the past. Once we get into the new financial year.
Yes, yeah. It won't be so. It won't be.
It'll be May
for April, but yes,
for May. Okay,
they will be more detailed.
The NIGC, Paul, you've been volunteered for something else, but thank you very much for doing that. Thank you. It's got a limited time horizon. This,
don't we all? Yeah, it's until March 2015.
Yeah.
Yes, so that's right. If I do there's a paper around the approval of the new chair, which is supposed to be me, and the report back from the meeting that I chaired as an interim. If I just do those two things together, is that all right?
Yeah.
So under the existing terms of reference, there is a non-executive chair of the National Information Governance Committee, which is an advisory committee, which was Steve Hitchens, who's now left to chair the Whittington, and the David, Chief Exec, had suggested that I chair that. Obviously, we'd need to chair an NIGC. That was discussed at the meeting with the committee and agreed, but it does need board approval to that and to change the terms of reference accordingly. So that's requested. As part of that March meeting, there was also discussion about who should be the deputy chair, given that because no deputy chair had ever been nominated in the past, it caused a problem when Steve left. There wasn't somebody who could step up, as it were. And John Carvell was nominated and unanimously agreed to that. I'm very grateful to John. As regards what we discussed then briefly in the March meeting, there was a desire from the committee just to revisit its programme of work so that it really did add the maximum value. I mean, I think a lot has changed since the committee was set up. A lot has changed in terms of the way CQC is doing its business, and the committee wanted to make sure that it was positive and as valuable as possible in discharging the legal requirements. There are two reports planned, one for the first half of 2014, and then a follow-up report at the end of the sort of the current phase of the NIGC, which is sort of March 2015. And the first report will focus very much on learnings from the initial waves of inspections. There was a really helpful conversation amongst the committee about the key lines of inquiry that we're planning to use in the acute trust sector, or in the acute sector, and how information governance plays into that. And it was noted there are a number of areas where information governance is included as a thing to consider, but there's no single key line of inquiry which really nails it down. This is where you would look. And I think we want to very seriously consider that challenge. So the most likely key line of inquiry would be the second one under well-led. So we're in the process of looking at that recommendation from the committee. We also had a good conversation about one of the pieces of work that would happen prior to the main inspection, one of the so-called pre-inspection processes, which was around information flows. And where there the committee's view was that was a very helpful piece of work, but that it would be helpful to draw the distinction between the willingness to share information that acute trusts and more broadly providers were exhibiting with the rest of the system, given how important that was for continuity of care, and also as distinct from the availability of good clinical information to guide the care within the hospital itself. And again, we will review the approach we're taking on pre-inspection around information flows as a result of that.
Thank you, Paul. Paul, and thanks very much for taking on that role. It's much appreciated. Thank you. John, you were going to give a report back from the Audit Committee?
I am indeed, and in order to assist the committee, I've prepared a written report which has been circulated while you were enjoying your dinner. I was slaving over a hot computer. I thought it would be more helpful to have something in writing, and which would, would avoid the interpretation of what I have to say being misconstrued or lost in the ether. And I want first of all to say thank you very much indeed to David and Hilary and Eileen, who spent a lot of time preparing for our meeting and a lot of time actually at the meeting, answering our questions and explaining a lot of the detail of the governance and the process and the detail of the transformation programme. The general conclusions that we have come to are twofold. The first is that on the first part of the programme, the high-profile part of the programme, which is the introduction of the new regulatory regimes for the and inspection regimes for the different parts of our overall sector. I'd like to echo, first of all, the comments that were made earlier in the meeting about the huge amount of effort and that has gone into delivering those changes and achieving those changes. And we were impressed both by the progress which has been made against, hugely demanding timescales and a very complex managerial task. And the conclusion is set out in paragraph 5 of my report, which says that basically that while not every specific goal has been met absolutely on time, but we can assure the board that there is an effective governance structure which is concentrating on delivering the scale of change needed and broadly on the timetable set. So we can give you confidence that those changes will be, have been and will be achieved over the life of the programme. That was the first conclusion. The second conclusion was on the second part of the programme, which is about changing the underpinning systems, processes, and the way in which staff are managed and manage the organisation, and the skills and training and experience that they have in order to do their job. And we strongly support the development of the academy as a way of achieving a step change in the skills and culture and approach of the people who work in the organisation. And perfectly understandably, over the period so far, the academy has concentrated on equipping the new inspection workforce, whether that has come from inside the organisation or recruited externally, with the skills they need to carry out the inspection programme. But that has perhaps inevitably led to a build-up of skills and experience and systems which need to be developed and changed, and on which the organisation depends, which have not been addressed so far to any significant extent, and which have slipped back into the later period of the transformation programme time scale. And we feel this is quite a serious risk facing the organisation and facing the transformation programme, and therefore we've not put ourselves in the position of trying to manage the programme. We've made two recommendations. The first is that we believe that the deliverables, the detailed deliverables, are set out in the transformation programme, which are currently specified until April 2015, need to be expanded and developed urgently to encompass the change needing to be achieved by April 2016. So there's a clear specification of what the programme is aiming for, particularly in that second category, until the period at the end of 2015-2016. And secondly, we believe that working back from those, it will be necessary to devote greater effort to planning this spring and summer what changes need to be made to systems and to staff development, bringing forward the start of these into the current, into the financial year which is just about to begin. Now, this is a really big ask because, as David has said before, the organisation is running hot. People are working at maximum capacity, and the most that is, huge amounts are being devoted to the progress which has been made and needs to be made in the future. But it goes back to almost a question about why organisations, complex, large organisations, have developed the concept of the balanced scorecard as a way of managing their operations. And that is to avoid a situation where the absolute priority to achieve some particular part of the organisation's programme squeezes out developments and change and investment, which is in the end going to be just as necessary for that organisation's success as the high profile part. And therefore we have made these two recommendations to the board, and particularly to David, that he should look at these. We've not prescribed exactly what the answer should be, but we feel that it's appropriate, given the need for this new structure of inspection regimes and regulatory regimes to be founded on a secure organisational base. And therefore we recommend that these, bringing forward the planning and the analysis that we've recommended should take place. I'm very happy to answer any questions, but in summary, that's what the paper says.
Thank you very much, John. Any questions to John? David, do you want to respond to the...
No, I mean, I think the board asked John and colleagues on the SCGC to have oversight of that. So there was some scrutiny yesterday for this quite a detailed and constructive discussion. I think it's really helpful that John set this out in writing, to be honest. And I think what we'll now do, I'll do this with Hilary and Eileen, but we've appointed, I think it's now out, but if it isn't, then Tracy Forrester will lead the work that we're going to do on the academy. That's a confirmed position. So we'll now sit down and actually review this 16. I think the balance that the board was trying to take yesterday is to have a constructive conversation with us, and by the same token, we were trying not to be defensive about what we've done. If everything's a priority, nothing is, and actually getting the inspections up and running, people into new jobs was actually the priority. Now the priority is making sure those people, and it goes back to the earlier conversation, are supported to do the job we're asking them to do and have got the skills. So I think it's a really good challenge, and we'll do that, David, and we'll bring something back to either the board or the ACGC in the next, if you let us get into May, and then we'll bring it back in May, and actually that just gives us time to get over the hump of everybody changing job in April and settle that down, and we'll report on this, by which time I think we'll have more people into some of the jobs that we need to create, so it will allow us to get it going. Again, I don't want this to sound defensive, but we've just had not some people in these jobs. I think we've had a conversation before about the risk we're at for having no HR capacity. Well, we've now got Tracy Dennison in, Eileen's arrived. We're making progress in actually building that capability and capacity, so we can actually tackle this at pace now. So it's, in short, it's a helpful report and we can build on it.
Good. John, thanks very much. Any other business? We've driven the public out of the room, except for one person. Is there any question you're burning to put to us? You're right, are you? Well done, thank you. Oh, you do have one, sorry. I thought you were saying you didn't have any. No.
An awesome responsibility representing the general public. Just one question. I come from an adult social care background, and I'm really interested in the learning that's taken place from the NHS inspections, particularly that credibility has been gained through expertise and team. Those seem to be two quite crucial areas, as well as data, obviously. I'm just interested to know how the Adult Social Care Directorate is going to build on that learning, because from my perspective, working out there, credibility for CQC is sometimes in doubt when there's not expertise about the particular services being inspected. And just how is that learning going to be embedded in adult social care practice?
Thank you very much. So the way that we're going to address that is first and foremost by creating the three individual directorates with a dedicated workforce focused on adult social care. So that's part of it. Second is within that, once we've got the management structure fully populated and the support available in terms of managing those teams, to be having discussions with staff about what their areas of expertise are, not so that we kind of just focus people just in looking at learning disability services or whatever else it may be, because there is benefit in actually having a read across into other areas, but to make sure that we're identifying where that expertise is so that it can actually support colleagues across the field. The third point goes back to things that we've spoken about at various stages through this meeting, and David has certainly mentioned, which is the support from the academy to work with our staff to enhance their understanding of the services that they are inspecting, and also to enhance the understanding of what good looks like in those services. So being absolutely clear about that, and using other organisations and other insight to help us to get there. So not thinking that we've got all of the answers internally, because we don't, but to bring that in. And then the final point is also to say that the inspection team, although many of the consistent bit of that team will be our inspectors, what we will also be having are experts by experience, people who have had a personal experience of care, either because they've used services or because they've cared for somebody using services, will be working alongside the inspector to do the inspection in the vast majority of the inspections that we will do in adult social care. And we know from the work that we've already done and some of the feedback that Mike's already had, and Paul was kind of talking about it only earlier in terms of the inspection yesterday, having those people who really know what the questions are to ask and who can really get underneath the skin of the service, that we'll get that insight. Over and above that, we'll expand the inspection team with specific specialists where that is required, as informed by the intelligent monitoring and the insight that we'll get from the data. So if, for example, there's a specific issue around medication that we think that we should be looking at, then one of our pharmacists will go along. If there's, when we're looking at hospices, as we will do from the Adult Social Care Directorate, we'll absolutely be making sure that there are people who are experienced and understanding of those services as part of the team. So it's a kind of round package, and I hope that's given some reassurance, but it is something that we're going to have to develop and learn from as we continue through, and obviously pick my colleagues' brains as we go.
Good. Thank you. Do pick it up over lunch with us as well if you want to develop that further. But I think just lastly to say, this is John, your last meeting. You may, I don't know if you've forgotten that or not, but you've seen sort of good times and bad times, I think, at CQ. They've been difficult in all kinds of ways. But can I just thank you on behalf of us all, really, for sticking with us and for all the sort of guidance, advice, and work that you've given us as well. It's been hugely appreciated. So thank you very much, John.
Thank you. Can I say just a couple of words? During my life, I've had a variety of life goals and ambitions, but I have to say that until I joined the CQC, chairing an audit committee was not one of them. And so it has been a new experience and a revelation to me. I do want to, but it does give you an amazing, perspective on the organisation. And I do just want to pay tribute to David Bean and his team and the staff of the Commission for, their dedication and their commitment to the work that the Commission does, but particularly to David and his team for the change that they have brought about in the organisation, which I think you've talked about, David, as well. And it has been truly impressive. I just want to say I deeply admire what's been achieved and respect what's been achieved. I have two brief words of advice for you all. That is, I think one should be careful to make sure that one under-promises and over-delivers. And organisations that promise to deliver more than they have the capacity to tend not to live very long. And secondly, I think it would be wise advice to stick to the knitting. All sorts of mission creep is imposed upon organisations, and sticking to the knitting seems to me to be wise advice given the scale of the challenge that you're facing. So thank you very much for giving me the opportunity of working with you all. Thank you for putting up with me, and thank you for providing at least 2 chapters of my memoirs for the future.
Thanks very much for those words, John. That's good. Well, that's it. It's lunchtime.